given an estimate of at least 10 minutes to present so that we can buy time. After the paper on human resources, we will have a paper on HIV and AIDS and TB performance in the region. Dr. Ephraim will be here to present that paper. Then we have a paper on regional MNHFP and nutrition situation, which will be presented by Dr. Jude. After that, we'll hear a paper from the regional malaria situation, which will be presented by Dr. Julian Abeso. Meanwhile, in the lower section, we will be having a paper on the overview of the performance of the regional blood bank, which will be presented by Dr. Bumba. Then we'll also have the status of drugs and medical supplies in the region. That will be presented by Mbale Regional Referral Hospital. Then we have One Health approach under the Elgon region. And then we'll have a regional RBF update. Challenge I usually get when I'm hosting conferences in the health sector, you people like to abbreviate things so much. So sometimes I have nothing to do but say it as it is, right? And then, of course, after the first 4 papers, we'll have a panel discussion, a Q&A session, where you'll be asked to, ask questions, and we will then deliberate. After that, then we'll get into the second phase, which will have a paper on private sector in supporting healthcare in the Elgon region. We'll have a presentation on ambulances and referral systems. We'll also have a presentation on community representatives. This side in the lower auditorium, we'll have the regional emergency preparedness presentation. We'll have non-communicable diseases and their risk factors, as well as the medical equipment maintenance in the Elgon region. After that, we'll have Q&A, and we will go for break. When we come from the break, we will all emerge here. We'll have an opportunity of hearing from Professor Maswa, as well as Dr. Sarah Biachika. After that, Dr. Watiti will also use about 5 to 10 minutes to present to us the status of HIV, AIDS, cancer, and palliative care. And then we'll get into our panel discussion, which will be focusing on the key resolutions from your different groups yesterday. And then we'll get into the closing remarks, where we've had a slight adjustment there. Dr. Augustine will come and give closing action points, and then we'll have Dr. Bo coming to officiate over awards and recognitions. After that, we'll go home. We'll have lunch and go home. You'll bear with us. We may have slight changes as we go along the way. Okay, so the other section, the main auditorium, will be facilitated by Dr. Imelda Tumhaire, who is the DH of Bududa. The lower section will be facilitated by Dr. Jonathan Wangutsi, who is the DHO of Mbale. Meanwhile, if you think that there's a paper that you want to, if you're here and you also want to listen to a paper, down in the lower auditorium, there's flexibility. Do not only stay here like all through when you're also interested in a paper that you may want to listen to. You may even want to listen to ambulances and referral system, but then you already are in this lower auditorium. It's okay for you to move and listen. Okay, let's do this. Why don't we now go down and break away? The people who are staying here can stay. The people who are going down can go. I'll give us 10 minutes strictly for that. You're staying here. There are people who want to stay in the main auditorium. There are people who are going to be staying, who are going to go in the lower auditorium. Enoch, put up your hand. Where is Enoch? Enoch is going to lead the team to the lower auditorium. And then the people who want to stay in the main auditorium can as well stay. Please don't all of you stay here. I can see no one is moving. Okay, thank you very much, Dr. Agre, for leading. Enoch, take people to the lower auditorium. Those of you who want to go to the lower auditorium, and those of you who want to stay, you can as well stay, and we get started. Meantime, I want to give us 5 minutes for us to start moving. I'll be back with Dr. Imelda, who is going to officiate and chair this section, and then I will also go to Dr. Jonathan downstairs. All right, 5 minutes. DJ, you can give us some soft music, thanks. Okay, it scares me that everyone has stayed here. Dr. Patrick, you're going down. That would be good. I wish I would divide us equally, but this is a democracy. I think you should. Okay, there is advice that we at least have equal attendance. How do you want us to do it? Should we go with 1, 2? We go 1, 2. Okay. So we'll start here. Everyone has stayed here, so I'm stuck. So what we will do, we will go with the 1, 2. The ones will stay here, the 2s will go down. And please don't move positions. I can see people ready to aligning. Okay, we'll start from here. You say 1, 2, 1, 2, 1, 2, 1, 2. Because downstairs I only have 5 people, and it's not fair. Okay? Is this a resolution? Can we do that? Yes? Yes, you were saying something. Okay. I don't want to be a dictator. Can we do the 1, 2? Okay. Okay, let's try it. Let's start with you. Okay. Guys, it's as easy as 1, 2. Simple. Okay? Okay, you're one. Okay. Yes. There's a I've been guided that some of you have just arrived, you don't even know what's going on. Okay, I'll say this for the last time, then we can get started. Today's program, because we had papers that were not presented yesterday, we had an overflow into today. And so we're trying to run paper presentations simultaneously in Auditorium 1 and Auditorium 2. The first main auditorium will be having these presentations, right? Each of the presenters will be given 10 minutes to present their papers, and then we'll have a Q&A session. And then the lower auditorium will have these papers that are going to be presented. After the paper presentations, we'll go for a tea break. Then we come and listen to the keynote from Professor Maswa and Dr. Biachika. After that, we will then go and have 10 minutes for Dr. Watiti to speak about HIV, cancer, and palliative care. And then we'll have a panel discussion to talk about the resolutions from yesterday's group meetings, and then we get into the closing session, which has award ceremonies, closing remarks, action points, and then we break off and go for lunch, and after that we'll go home. Is that clearer now? Great. So those are the papers that are going to be presented in this auditorium, but we also have papers that are going to be presented in the lower auditorium. So I had asked people to select the papers they want to do, but I've seen everyone has stayed here. So it got me scared that we can do the 1, 2, which some people want, others prefer to say, look, we want to listen in to sections that appeal to us and the work that we do. So it will be unfair to divide us into 1 and 2 when our interests are elsewhere. Okay, let's go with this. It's your choice. You've decided to stay here. I will respect it. For people who are going downstairs, please let's go. Let's start. Let me invite Dr. Imelda. I think the 1, 2 may not work because some people are interested to listen specifically to some papers. And so denying them that opportunity would not be fair. Dr. Imelda, I want to invite you to now officiate over the first paper presentations. Let me also go down and support the team downstairs. You're welcome, Dr. Imelda. Karibu.
Sorry. I'm Dr. Tumuhirwe Imelda, the District Health Officer of Bududa. I also represent the DHOs as the Chief Executive at the national level of the Eastern region. As the MC has already talked, our first presenter is on human resources for health status in Elgon region. He's a public health specialist, a technical advisor, human resource for USAID, Uganda Health Activity, Mr. Balondemu Enoch. You are welcome. Strictly 10 minutes.
distinguished guests, the Director General for Health Services, the RDCs, the Chiefs of Parties, distinguished guests, ladies and gentlemen, protocol observed. My name has been mentioned. I work with USAID Uganda Health Activity, and I'm going to provide a status of the human resources for health in the region. That is going to be our presentation outline, where we'll look at the situation analysis, some bit of background, some bits of staffing levels. It was a hot discussion yesterday when we were looking at staffing levels. We want to understand what is the status as of now, the key achievements that we've registered, then absenteeism rate, the high impact interventions, then what is our take-home message and the key asks. We understand that we all need quality services that must be provided by competent, skilled, supported health workers at all levels. So human resources for health deals with health work, any persons that support to protect and promote health services. And we are looking at VHTs and those that are in non-formal training institutions. As a region, we have about 6,300 and close to 6,400 staff. And these are coming from all the public institutions. However, we have staff that are registered from the private facilities. They contribute around 450 something staff. However, when you look at the staffing levels, as a region, we stand at 33% according to the new structure. 33%. And the breakdown is as below. You see, we have 7 general hospitals in the region, and we stand at 42.9% for all the general hospitals. Mbale Regional Referral Hospital, when you look at the old structure, they were at 116%. However, when you use the new structure, they're at 37%. And we have 205 public health center 3s, where we now stand at 22.1%. You recall yesterday that most of our clients visit the nearest facilities, and these are the health center 3s and the health center 2s. That is the staffing level. Health center 4s, we have 19 in the region, and we stand at 31%. However, in the old structure, we stand at 102%. These are some of the key achievements that we've registered over time. Some of those faces are familiar to us, like that face of Dr. Kenneth Mugabe that leads the Elgon Region Maternal Neonatal LNMS program. We've registered an increment in terms of staffing when you look at the last financial year. True, we stand at 33%. However, there was some slight improvement from 79, from the old structure, from 79 to 84%, close to 84%. And there has been some decline in absenteeism rate. from 49% to 19.7%, which is an achievement. And we'll look at the details in these achievements and what it speaks to, these achievements that we've registered. We've enhanced the capacity of health workers in the different disciplines, family health, TB, HIV, in the different disciplines, using the different partners that we have in the region, but also the stakeholders, the training institutions, and including the performance management functions. We have the VHT structure that has also been empowered to do their work, including the health unit management committees that have been trained across all facilities in this region. They have been oriented. The only challenge that we have is that some of the HUMICs tenure is soon ending, where we need the lower local governments need to reappoint new people, and then we support the orientations. We've also strengthened the leadership capacity of the health unit managers in working closely with other partners, that is AMREF, where some districts have been trained in the leadership skills as health managers. Some of the retention and motivation strategies, some districts have embraced it, where health workers have been motivated, and this has promoted retention of health workers. Mbale, Kapchora, Bududa, Sironko, Kwen, these are some of the districts that have had innovative measures to retain and motivate their staff. And also embracing the digital health technologies, where health workers now, instead of, we have a record called the electronic medical records, where health workers just register information on their clients, but also the reporting system designed by Ministry of Health, which is the Integrated Human Resource Information System that captures information of staff right from the training institutions up to exit, which is retirement. The collaboration and partnership, which is very key, and it's the reason why we're here today, right from the districts, the partners, the training institutions, and all stakeholders. That is a bit of deep dive into the absenteeism rate. You see some of the districts, like Bududa, Kwen, Kapchora, this correlates with the performance. We rank districts and facilities according to the National League Table indicators. And this absenteeism rate per district correlates with the performance of the districts. You see Mbale, currently that stands as one of the #1 districts in the region. You see the trends from 41 to 7.6. There is a lot that they have done, including spot checks. There's a lot that these districts have done, but you can see Mbale as a district that has only one health center for Busiu, which is their referral facility. Not only using the biometric machine, you see that picture has even the registration. So someone clocks in, just in case there is no network, someone also has to write. That is a picture taken from Busiu Health Center 4. The rest applies to some of these districts, Kwen, Kapchora, and Bududa, Budaka. We still struggle in some of these other districts like Tororo, Sironko. Palisa has come up, where Palisa Hospital is now planning to recruit a face technology biometric machine using the resources that were allocated to them. So which is a good progress towards having an achievement in responsiveness and empowering health workers to do what they're supposed to do. These are some of the high-impact interventions that we think can support the performance of the health workforce in the region. Data use, where together with the districts, they use support supervision reports. Support supervision reports right from the health sub-district and the districts, and these reports are discussed at DHT. We have a DHO's forum in the region, and in those DHO's forum, data is key, like discussing absenteeism. Some of the issues that come out, all DHOs declared that going forward, it's our own duty to do spot checks. So our role as partners to support them, support the process. Task shifting, we have many partners that are supporting this process of task shifting, but also we have LPHS, where we have support staff, the peers, the linkage facilitators that help beef up the limited health workforce that you have in the facilities. As evidenced in some of the lower picture, you see that is a VHT or a mentor mother. The health worker is, the VHT is, I don't know whether it is very clear, but the VHT is doing some of the preliminary works that don't need high-skilled, but when the health worker is doing the high-skilled. So we've done a lot of strengthening the performance of the health workforce, right from the district, where we've oriented the principal human resource officers in the current performance management functions, but which has to be scaled down. So now as a region, we want to hear from the DHOs, what is it that has been set forth to ensure that our health workers continue to be productive and responsive. The self-awareness, staff awareness and support, we very well know that our health workers are at the front line when it comes to some of these public health threats. So we want to ensure that health workers take lead in making sure that they are well catered for. So what we've so far done is ensuring that the IPC committees are in place. But what we also request is to ensure that these health workers are supported when it comes to compensations, but also understanding the process. Digital technology, I had earlier alluded to this, where we have now systems in place to support record and reporting of information. Leadership management is very key and vital, where we now have the HUMICs right from the grassroots, fully functional, and the support structures, health sub-district, and the DHTs, including focal persons, assigned and doing what they're supposed to do. Support supervision, I had earlier alluded to that, and mentorships, which are ongoing. These are some of the key challenges that have been registered over time. And I had earlier mentioned to the shortage of skilled workforce, especially in the rural areas. And however, we as partners and stakeholders, we've supported in beefing up the staff through task shifting, and also we've also asked the district to have in place tailored staff retention and motivation strategies. But you see, that is the status of Mbale Regional Referral Hospital. The other one is the neonatal unit, and the other one is the pediatric ward. You see how overcrowded it is, just because of shortage of staff. Leadership capacity, that one was earlier even alluded to yesterday, where we want to enhance the capacity of health facility in charges, in leadership skills. In some of these training institutions where they are coming from, leadership schools and is not a priority. Also enhancing accountability and reporting. Data use, I had earlier alluded to this, where we want to functionalize the human resource information system that captures health workforce data right from the training institutions, private facilities, PNFP facilities, such that as the unit, as the region, we know what is the current status of health workforce that we have that can support us deliver the health agenda. Then the performance management, inefficient performance management systems, where we want to roll out the support, the Ministry of Public Service roll out the balance scorecard, and also putting clarity to the key performance indicators. Ministry roll out the key performance indicators for all regional referral hospitals, but now we want it to be scaled down to the DHTs and health facility in charges. That is our take home, and we are saying we need to invest in sufficient wage allocation. We heard from the plenary yesterday that is top on the agenda from the high authority. Training and capacity building, infrastructure, and a strong workforce. Then we need to collaborate to foster strong partnerships and encourage coordination and alignment of efforts towards the health workforce. Then empowering communities, health workers to use data, first of all for their professional growth, but also to address the gaps that are existing in these facilities. We also want to empower community feedback initiatives, for example, the one that was launched by Minister of Health to improve on service delivery. Workforce diversity, and that is our ask. A waiver, like you heard yesterday, we have 5 districts that don't have substantive DHOs in the region. We want to request Ministry of, we are privileged to have Dr. Driwale here. We need a waiver on job specification for DHOs. We have districts that have had non-substantive DHOs for the last more than 7 years. And then Ministry of Finance to provide adequate wage. And then public service on approved structure for DHOs. We don't have approved structure for DHOs yet. And then procure biometric machines. That was an outcry from even DHO Captura yesterday. It's one way of ensuring responsiveness of health workers. Hasten the use of the integrated human resource information system, integration, such that we can measure productivity of our health workers. I thank you so much.
Thank you, Enoch, for ably delivering your information and on time. Now the second presenter is from Mbale Regional Referral, is a consultant obstetric gynecologist, head of Department Obstetric and Gynecology, has a work experience of 15 years in maternal and newborn health. I request Dr. Jude Glowoza to come and give us the experience. You are welcome, Doctor.
Good morning, colleagues. All protocol observed. What is my presentation? Moses? Presentation, please. I've already been introduced. I welcome you all to this meeting. I thank you for sparing your time to come and have these important deliberations to improve on the situation in our region. Next slide. Who is helping with the slides? Thank you. So, I think I need help here. So, from the presentation yesterday, we heard from the representative of the DG that our regional referral hospital has been the best in the country over the years. And these are some of the key performance indicators for the region. So you notice that our perinatal mortality rate is 11.5 per 1,000 live births. And you can see the target. According to this, we've actually achieved the target. But in my opinion, we need to do more. Our teenage pregnancy rates have reduced to 20.5, and that is less than the national average of 24. And the ANC attendance in the first trimester is at 42%. We still need to do more to achieve our target of 70. The maternal mortality ratio for the region is 75 per 100,000. That is much less than the national figure, which is 189 per 100,000. Should we clap for ourselves? We are still struggling with high fertility rates, especially for Bukit region, which are 6.5 against the national 5.2. And they are still grappling with malnutrition, which has actually increased over the years to 1.1 in the under 5s. Next slide. So these are some of the achievements. You notice that we have, when you look at the previous 2 years, we have noticed an increase in the key performance indicators, including the ANC1. As you can see, green is 2022/2023, and then red is 2023/2024. You can see that there's generally an improvement in ANC1. There's an improvement in first ANC in the first trimester. There's an improvement in ANC4, an improvement in total number of deliveries, and an improvement in the postnatal care attendance at 6 weeks. So now this is a slide showing the mortality data, both maternal and perinatal. You notice that what is in blue is the regional picture, and what is in red is the contribution of the regional best. Of course, there are limitations, but the fact is the referrals usually are not good referrals. They come in late, and these are complicated cases. So some of them are actually difficult to save. So you find that what you are seeing at the regional referral hospital is a mirror image of the region. So the mothers who would have died at the lower levels end up dying at the regional referral. These can be saved if they can be referred earlier, or if they can be worked on earlier by improving service delivery at the lower level facilities. Of course, the regional referral also has challenges, including space. You heard yesterday that we have one operating bed for the obs and gyn. That means the decision to incision time is prolonged. Mothers wait for a minimum of 2 hours to access an emergency operation. And on average, in 24 hours, we do at least 10. And so if a mother is going to wait for 2 hours, the first mother, what will happen to the 10th mother? So those are some of the challenges that are contributing to the high maternal and perinatal mortality in the region. So the commonest cause of maternal mortality is hemorrhage and maternal sepsis and hypertensive disorders are second. They are neck to neck. And then, of course, the other complications combined contribute 15%. Now, this is a slide showing us how we are performing in terms of C-section. You know, an emergency section is usually prescribed when it is deemed safer for a mother and a baby than a vaginal delivery. So it is expected that at least 15% of all the pregnant mothers will need a C-section. So if you have C-section rates at a population level less than 15%, it means there is a big unmet need for C-section, and therefore you are getting bad outcomes. Now, when you look at our region, this is population data, not facility data. So you find that for all the districts, they are actually underperforming in terms of C-sections. There are so many mothers who need C-sections, but most of the districts are not able to provide this. It's only the Regional Referral Hospital, which is at a C-section rate of 18%. I mean the city. Of course, the city has the Regional Referral Hospital and the private facilities. So that's the only district which is offering the required proportion of C-sections. So as a region, we need to do more to make sure that we offer C-sections safely and timely in order to improve the outcomes for the pregnancies. We are struggling with maybe before I go to the next slide, you notice that the worst performing district in terms of C-sections is Kweni, and you know the reason, they have no anesthetic officer. So that 0.5% is because of borrowed hands from Kapchora. When you look at Namisindwa, same thing, they have a PNFP. Of course, there is some paying there, so some patients will not manage to pay, so most likely they end up getting referred. When you look at I think those are the worst performing districts in terms of C-sections. Mbale district is also still struggling at 3.5. We know they have a busy center 4, but however much it is busy, I think the population is big, so we need to do more, and especially to be able to provide C-sections at night. You know, we have challenges with accommodation for the doctors and the anesthetic officers, so we are unable to offer C-sections in Mbale districts at night. So we need to be supported to address that issue. When it comes to immediate family planning, this is family planning within the first 48 hours after birth, we are still struggling. Remember, if you don't get pregnant, then you cannot die from PPH, right? So improving uptake of family planning is going to go a long way in reducing the maternal death in our region, and of course reducing on the congestion at our facilities. But as you can see, we are still struggling seriously in providing this. And as you can see, the poorest districts are still Kweni, Bulambuli, Bukwo, Butaleja, Palisa, and Manafa. Teenage pregnancy rates, I said as a region, we are doing a little better than the national average, but we are still struggling in some districts. There was a surge during the COVID time, but I have seen a reduction to 22% currently. Of course, the city is shining, maybe because people have access, people are sharp, the teenagers are sharp in the city. But when you look at Bududa, when you look at Namisindwa, when you look at these 3 districts, this is still a problem. So we need to do more. Of course, the teenagers who become pregnant are likely to get complications, obstetrical labor, PPH, preterm delivery, and others. So we need to do more. We shall definitely discuss on how to improve that. Now, just to talk about our local maternity and neonatal system for Elgon, it was the best LNMS in the country last year. Thank you. So it has been able to lead all the safe motherhood campaigns in the region, including preeclampsia, PPH, sepsis awareness, through radio, talk shows, church, and community talks. We have organized trainings for health workers, including midwives, doctors, and anesthetic officers, and others in use of specific high-impact molecules like Combipac, interventions in treatment of PPH, improved identification of high-risk pregnancies, among others. We've improved awareness of these interventions in the region through the LNMS. And of course, support supervision is ongoing to the lower level facilities. We are able to do weekly meetings every Tuesday, through which we discuss issues affecting the region, including maternal and perinatal death reviews, and of course, redistribution of life-saving commodities. You know, one of the issues here is stockouts of life-saving commodities. So through the LNMS, we have been able to redistribute. And of course, the biggest challenges, we have some health center force which are not functioning, and they have doctors, and the doctors were enhanced, and the doctors come there. So we are underutilizing the doctors. Someone said yesterday that there is a problem with efficiency. How do we use what we have? So you have a doctor going to the health center for and treating simple things. And of course, mothers who really need the doctor to intervene cannot be helped because of lack of an anesthetic officer, lack of equipment. A facility like Naviganda Center 4 is one of the most referring facilities at the Regional Referral Hospital, and it has not performed a single C-section in the last 3 years, and it has 2 doctors. The only problem they have, no equipment in theater, no anesthetic officer. My prayer is we get a solution to help in Naviganda in this meeting. Of course, places like Mbale are trying to work amid this lack of anesthetic machines. That means the anesthesia is not safe. And then Tororo has facilities which are not functional as well. Mulanda has not been able to perform a C-section in the last several months because of shortage of anesthetic officers. Of course, you had the issue of a ban on recruitment. It has affected the whole region. People have money, but they can't recruit, so the money ends up going back. Allow me to finish with this slide. So the key asks we have, first of all, we hope and pray that the ban on recruitment is lifted so that districts are able to recruit the critical human resource within their places, so that the local facilities and the district hospitals are able to function fully. And this, we think this is going to reduce on the congestion at the Regional Referral Hospital. The other ask is to expand the delivery unit at Mbale Regional Referral Hospital. We don't have a maternity ward, let me say that. We only have a delivery ward with 6 beds, and as I said earlier, we do 30 deliveries in a day, and we only have 6 beds. And then we have only 1 operating bed. There is no space to put a second one. So what happens? You can only have 6 mothers on ward. The other 24 mothers are at large. They are all over. They're in the corridors. They are at the gate. So monitoring becomes a problem. It is hard to be in charge of the process of labor in these mothers. So some of them end up getting bad outcomes. So our ask is that we get well wishers to expand our unit to be able to accommodate our mothers and also work on them timely to improve the outcomes. I think in the interest of time, I beg to end there. Thank you so much.
Yeah, thank you very much, Dr. Jude. I know there are many questions. I will request all the participants to keep noting down the questions. Time will come. The next presenter is going to share experience on performance of HIV/TB in our region, what works and what are the gaps. And this is Dr. Ephraim Nakoko, District Health Officer, Manafa. Dr. Ephraim, you are welcome.
Good morning, ladies and gentlemen. Thank you for giving me this opportunity to talk about TB HIV. Can you help me? Okay. That is our outline, and we are going to emphasize those key outlines so that we, at the end of the day, we pick what we want the key stakeholders in the house to understand. I'll beg to begin. Protocol observed. Director General, we recognize your presence. That is a brief background that the national HIV prevalence stands at 5.1. As a region, we are at 4.2, slightly lower than the national prevalence. And according to the Uganda population-based HIV impact assessment, 2020-2021, it shows that the HIV prevalence in children, in young adults, is more in the young girls than the boys, as you see the statistics there. And the ART coverage is still low in this young population. Even the viral load suppression is still low in the young population. When you look there, you are seeing the first 95, second 95, and third 95. As key stakeholders in the house, I want you to understand that the first 95 means that it is all about awareness. That we want 95% of people living with HIV aware of their status, that I'm HIV positive. And those who are aware that they are HIV positive, 95% of them should be initiated on antiretroviral therapy. Then, those who are initiated on antiretroviral therapy, 95% of them should have their viral load suppressed. What we mean by viral load suppressed is we want the virus to be in undetectable levels such that these people can live a very good and productive life. That is the first 95, second 95, third 95. And this is our picture as a region, as far as those 95s are concerned. Down there, you'll see the total. Our Mbale region is that the first 95 we are at 99%, we are in green. Second 95, we are at 101%. Third 95, we are at 91%. So this one shows us that we are doing very well as a region in that aspect. Save for the third 95, where we are in yellow. I'm not meaning yellow as a bad color, but in our statistics here, it shows us that we are moderately performing and we need to improve. We need green all through. And you see the reds have reduced from the last financial year to the, compared to this current, the financial year 2023, which ended 2023, and the financial year ending 2024. You can see the rates are reducing. And this one clearly shows you the impact of our implementing partners in the region. What is working for a region is risk-based facility testing and use of self-testing is really working for us as a region. And we have better ARVs like dolutegravir. Areas of improvement, we need the multi-sectoral approach. Stigma is still a high on the agenda, and we want the RDCs in the House LOC5s and all partners here to help us reduce the stigma. And the family support for people living with HIV. And the transmission from mother to the child is still high. HIV transmission in the region, we are at 2%. And you can see that what is causing that as a region is that we are having most of our mothers, we are getting them HIV positive when they are pregnant. So which means they are living with the virus, they are not testing until they become pregnant. When we test them, we find them that they are HIV positive. Another thing is community deliveries are still high in our region. It delivers in the community and is HIV positive. And we call for action still, the multi-sectoral approach. We need the key stakeholders here to take this very important, and we need sensitization of our communities. And the key to note is that all our infants started on ART, and the highest transmission rates in our region are in Kwen and Butaleja. Take-home messages, availability of competent staff. People have mentioned this several times. I will not repeat it. Client literacy is key. So the higher the literacy rates, we can achieve the 3095. All districts need to leverage community structures. That's why we have religious leaders here, we have the business community here, and we have the political wing, so that we utilize all the structures to fight against HIV. The regional picture on TB, you can see that case detection, we are improving. We are at 102%. We are doing very well as a region. And a special thanks to the Iron Lady in the House, Damali, who is pushing us left and right to have this achievement. And the partners, thank you for supporting her. Those are our strategies which are working: active screening at all entry points, and community TB screening using the TB. We have the van. Thank you, Commissioner, for giving us the TB clinic van, which is doing wonders. Then we have the community awareness, screening and testing TB campaigns. This is where I call on the political wing and the religious leaders to embrace, to make calls and follow up. Then flagging the TB cases eligible for sputum follow-up, that we need to test your sputum every now and then, after some specific period. So we flag them so that they are easily followed up. And improve the management of TB, HIV co-infection. These are brothers and sisters. So, but we, as a region, we are managing these cases very well, and hence our good outcome. Strategy for improvement is monthly cohort monitoring of active patients. That is, as a region, what we need. I just wanted to challenge the region with that table. Bukedi region still continues to be a bully in the house by performing very well in the TB management. You see the first three positions, but we are going to regroup as Bugisu and overtake you. Special thanks to Mbale City, which has come from very far, and Mbale District. This time you have displaced me from Manafa, but we shall come back stronger. So these are the avenues. For us, it is friendly. You check me, I check you, so that we improve as a region. So there are nothing attached here. We just check ourselves. Take home messages. TB is preventable and curable. So if you have forgotten everything about TB, just go home and say it is preventable and curable. We need all stakeholders in TB case finding and management. You have opportunity at Barrios, Speak TB. It is a call for all ministries, departments, agencies to work together to fight TB in our communities. And partnership is the way to go in the fight against HIV and TB. Requests. Ministry, we request that we accredit facilities, the health center 3 which are newly upgraded, as either they offer art. Then effective supervision of health workers to improve accountability. I can assure you that health is for all of us. And there is no way you are going to live for only health workers to improve this. So we need all of us on board. We move as a team. Those are our IPs who have supported us to have this function. My time, so that I finish at exactly 10 minutes. Thank you for listening. God bless you.
Thank you very much, Dr. Wakoko, Dr. DHO Manafa. And I thank you very much for being time conscious. So our next presenter is a pediatrician from Mbale Regional Referral, and is going to take us in the regional situation for malaria. And this is Dr. Abeso Julian. Dr. Abeso, you are welcome.
Thank you so much, Dr. Imelda. And good morning, ladies and gentlemen, in your various capacities. And I welcome you all to this assembly. I am going to talk on behalf of the child in this region and the people looking after the child. By the child, we are meaning children who are 0 days. Okay. Okay. So by the child, I'm meaning children who are 0 to 18 years. And for this presentation, you realize that Dr. Jude has already talked about the child who is less than 1 month, the newborn, and that is the presentation outline. This is our analysis in this region. You can see that in immunization, we are not doing very badly. Of course, we are still doing badly in some areas, and we are going to look at it in detail. And the next slide, we look at the newborn. I'm just giving a glance, although Dr. Jude has already looked at it. This is the newborn unit at Mbale Hospital. What I want to emphasize here is that the facilities are available, although you can see that it's a bit like there are very many patients, very many mothers, but you can see there is a bit of equipment. This was in Mbale. Mbale also has a newborn unit, but it's not very well equipped, but at least there is a unit. And this was an innovation in Kapchorwa. It's a very good innovation, but I think it's a bit risky because I'm not sure that baby will survive. So it's good for us to do innovations, but sometimes they may be risky innovations. So the next slide is just looking at our performance in immunization. And by red rec, we mean reaching every district or reaching every child. You can see that most of the districts in this region are performing very well. However, there are some districts which are still in red. Red signifies danger. So those districts are still not doing very well. And these are districts of Tororo, Kibuku, Butaleja. And you can see that most of those are actually in the Bukedi region. And because of this, we've actually, at the moment, we are having an outbreak of measles. And as of today, in Mbale Hospital, we have about 3 cases of measles on the ward. And in these regions, in these districts, we are having so many cases of measles at the moment. We are doing mop-up campaigns and hope that in the next 2 months, we shall be at least doing better than this. The burden of under 5 illnesses in this region, you realize that our data is mainly concentrated on the child under 5, but there are also children above 5 who fall sick. And from this, you can see that the highest burden is malaria and cough and flu, and those are preventable still. Now, when we go to the burden of malaria in the under 5, in 2021, the malaria burden was a bit smaller. Then the peak was between 2022 and 23. And I can assure you that in that peak, we ended up losing a lot of children. As I talk now, the peak is going down because so many interventions were done. We had to go and mentor the health workers. We changed the guidelines and requested for commodities and all those things. But of course, we are still having very many cases of malaria. Now, this next slide, I don't like it so much because it shows the death. And no health worker goes to work expecting patients to die. So when a patient dies, we are actually affected, and it also affects our service delivery. So you can see in this that we lost a lot of children between 2022 and 2023, and most of it was because of malaria. So you realize that the outpatient attendance for children is driven by respiratory conditions, but inpatients and death is driven by malaria. And in this case, you see there are some patients who died in outpatients, and those ones who died in outpatients are the ones who died on arrival. Like children come and they've already died. So that's death on arrival, and it's totally unacceptable. It should not happen. Now, the achievements. As a region, we have had so many achievements for the newborn. Like in the regional referral, we have a newborn trolley. It contains oxygen, everything, so you can transport the newborn very safely from the maternity to the newborn unit. We also have a breast milk bank, a bank that stores breast milk for babies whose mothers are not able to give them breast milk. Then we have also had a number of achievements, like we have had research publications, and at the moment we are doing a big research on patients with sickle cell, and we expect that it's going to change the face of sickle cell in this country. We have partnerships and collaborations with Busitema University. For us, we have our pediatricians. We actually train them from Busitema University. So Mbale Hospital and the surrounding will have enough pediatricians in the next 3 years. And then we seed global UHA and community groups. Like in Tororo, there's a community group, Joseph and Jude. They help looking after patients with sickle cell. Then in that picture there, you can see up this Busolwe. They have a new children's ward. And then down, you can see Budaka also has a new children's ward. And for us, those are big achievements. These are the key challenges. Most of them have already been mentioned: extortion, poor attitude, and the rest. I won't go into it. But one of the biggest challenges is the changing disease patterns. You can see that now we are getting a lot of malaria, but with a lot of complications that originally were not there. And because of that, it's giving us a lot of challenges in the management. Now, the other big threat is that as I talk now, we have stocked out of anti-malarials in almost this whole region. And you're expecting us to do wonders, but how do we do it when we even don't have drugs? The crowding, that is an issue. And I remember HMU came and they asked me why the ward was crowded, and I told them that, do you want me to chase customers? So if the patients are coming, it is hard for us to chase them. Now, our ask, what do we ask for as the children of this region and the people looking after them? First of all, we would like that we promote prevention, because malaria can be prevented and all those things can be prevented, cough, flu. So why should we be struggling looking after cough, diarrhea, when those things can be prevented? So we want an integrated service. Maybe we can borrow that van as they are moving around for TB. They also talk about malaria prevention, sickle cell, and all those things. And we also want to strengthen the adolescent services and promote child-friendly services. The children want us to look after them in a place with walls which have child-friendly colors, cartoons, and so on. But for time, but actually it's very important for a child. So we need to promote child-friendly services. Then the other thing is that for the adolescents are children between 10 years to 18 years. Most of them are actually being looked after in the adult wards. Imagine a 10-year-old looking at a museum, being dressed. So how does that happen? The only place in this region which has an adolescent ward is actually Busolwe, the new ward. And we really thank the person who donated that facility to Busolwe. Yeah. So we would like the adolescents to be looked after better. They should be considered. They should have a place where they can air out their views freely without being disturbed. So as the children, we have few asks. We are not asking for very expensive equipment. We just want few things. And of course, more research, because like I said, there are a lot of changes in disease trends. So we need to do more studies to find out why. Thank you so much. And I would like to acknowledge all the people who helped us in this health assembly.
Thank you very much, Dr. Beso. And this one being our first presenter, it marks the first session. We are going into questions and answers, and we have 10 minutes. I'm going to request all the presenters to come and take up the front seat. And we are going to take 5 questions in the interest of time, because we are allocated 10 minutes. So we shall take the first 5 hands, and I will request the presenters to note the questions that are asked. I request those questions to be short, smart, and to the point, and 1 question per hand raised. I'm going to request Dr. Buyinza, the DHO Chibuku, get the mic, and you pick the people who have the questions. Meanwhile, the presenters, you are welcome to take the front seat so that you can answer some questions which are going to be raised. We shall need a mic. I don't know who can avail us with the mic. Yeah, I'm seeing If the mic is available, Dr. Buinza, there is a lady's hand behind you.
Thank you very much. I appreciate all the presenters. My name is Alpo Scholar. I am concerned as a mother, as
I will
daughter,
request
and
if
also
you are,
as a-
excuse me, I will request if you are asking a question, tell us your name and your title, and maybe the district you are coming from.
I'm Alpo Scholar. I am the Deputy Cow Busia District Local Government. I feel so perturbed with this bed, the operating bed for mothers. Surely the whole region cannot afford another bed. How many should we continue losing? Should we wait for next year again and come and lament about the presence of one bed and our failure to plan accordingly? It's disturbing me as a mother, as a girl child, and also as a leader at this level. Thank you very much.
Thank you very much, all the presenters. I'm called Connie Wheeler, Assistant District Health Officer, Maternal Child Health, Tororo. We are limited. Let me just look at one thing. When I looked at the leading causes of maternal death, sepsis is number 2. But I have this to say. From all the presentations I've observed, one thing is contributing to these issues of space, issues of beds. What we are doing in our facilities, a Caesar mother is being put down. When you bring in a new case, you have to put a mother down. A Caesar mother, the space is small.
Find are treated and return home healthy, or when they are okay. What will be the issue? Thank you.
Yeah, thank you. Stephen Wasike Mugeni, the district chairperson, Busia. I was particularly touched by the revelation that Busia is the worst hit district in staffing level, 51% old structure, and less than 30-something% new structure. Do we have a systematic arrangement where we say, for you, we shall enhance your wage to bring you up to the level of others? Are we just going to continue looking at them? Next year we look at them, Busia is the worst, we do the same story. Do we have special arrangement for bringing us to the level of others? And then the second one is types of TBs. In Busia, we seem to have several TB types. I want to be educated a bit more on them. TB of the lungs, TB of the eyes, TB of the nose, TB of the bones. Do we have, when I was studying, I didn't have that. Is this a new development?
Imran Muluga Haji, RDC Namisindwa. Yes, I'm not surprised that when the figures are there, Namisindwa is performing poorly. And we are also losing many mothers. The terrain of Namisindwa cannot be over-explained. We have a forest, we are a home of landslides. Mention it. But I'm happy that the Commissioner Emergency Services is here. I've raised this before. We don't have a health center for government, and therefore we don't have doctors in the old structure too, who are supposed to be at the health center for. We don't therefore have these cesarean operations. Mbale which is trying, not for profit, it is 300,000, the cheapest cesarean operation, to 500,000. I'm talking as the RDC. I have that information. You gave us an ambulance, and I'm told the guidelines of the ministry, the ambulance should be at Health Center 4. Even the mothers who failed to produce in the Health Center 3s cannot go to Mbale and access an ambulance because they know that things in Mbale are for payment. So we don't have an ambulance. The District Security Committee, in their wisdom, resolved that this ambulance should be shifted to a Health Center 3, where mothers fail to produce, they should be referred to Mbale because they cannot pay the 300. When I raised it, Commissioner, Emergency Services, you said you know that could be politics, you have followed the law, but we are giving you the facts on the ground. And we are disturbed that we continue to come here and you are giving us figures of Namisindwa leading in mothers dying, and yet we know this, and we can't solve it. How I wish that you guide and we shift the ambulance, since we cannot have cesarean operations, at least we can save lives by bringing people to another health facility, which is government. So that is the dilemma. So I'm not surprised when you rank us the last in this country on matters where government has participated. You know, the other day we were in Munyonyi and they were ranking districts. You have a health center 4, you get 5 marks. You have a hospital, you get 10. You don't have a health center 4, you get 0. You don't have a doctor, you get 0. You don't refer, you get 0. How do we refer when we don't have an ambulance? I rest my case.
Yeah. Thank you very much. I think we have picked the 5 questions. I know the presenters, you are going to ask where you can end. And then I will also request the representative of the Director General to take up some questions and try to help us to give us some answers. But meanwhile, in our presence, we are blessed to have in the House Professor Omaswa, one of our keynote address speaker. I think let us welcome him. Please, round of applause. Thank you. So, in the interest of time, I don't know whoever is ready can begin. Just pick the questions which has been addressed to you, and then you answer. We have a question from the Deputy Cow of Busia District Local Government, and it was on the beds. I think Dr. Mlowoza, will you be able to answer that?
Thank you so much. I think mine is just, one was a comment. Someone was wondering why sepsis is high. Of course, people have become more informed about early detection of sepsis, so the reporting is more, and so the data is being captured more. That is one of the reasons why it is now ranking as number 2. But efforts are ongoing to improve the knowledge of the health workers in the region on how to identify and manage mothers with maternal sepsis. The issue of the operating space, actually the problem is not the bed. We can get the beds. Actually, a bed is not very expensive. But the problem is the space. There is no space where you can put a second bed. So we have reached out to our partners to see whether they can support us to expand the theater so that we can have more than one operating bed. The discussions are ongoing. We hope that eventually we shall succeed. But in the meantime, we are trying to access the main operating theater, which is far away from the labor suit unit, and it takes not less than 30 minutes to access, but also getting a team to work on the patient is a problem, because that theater is used by the rest of the hospital. So in the meantime, we are using that, but we are advocating for expansion of our theater at the labor suite to be able to work on more patients at a time. Thank you.
Thank you very much. Dr. Abeso, there was a concern about children urinating blood. I think you are in a better position to educate us.
Thank you so much. The issue of children passing bloody urine is a complication of malaria. In most cases, it's called black water fever, and it's a common complication in children in this region. But there are also other conditions which can cause them to pass blood in urine, like sickle cell disease. So as a result of this, Mbale Hospital has been very instrumental in coming up with guidelines for managing children with black water fever. And Mbale Hospital won an award this year from the National Malaria Control Program for being on the front line in changing the guidelines for treating children with malaria who have black water fever. And as I talk now, you know that the number of children who pass dark urine has reduced. And what we are doing is that we are mainly concentrating on prevention. Because if it is malaria causing them to pass black urine, then we have to prevent malaria so that they don't end up with that complication. And the children who have had that complication before are at risk of getting it again. So what we are now emphasizing is that they come back for review at least once every month for the 6 months, and then eventually, of course, if they are stable, then they don't need to come back. So we have opened clinics for sickle cell in Masafu, in Tororo, in Manafa, in Bugobero, Busiu, Budaka, Palisa. And in those clinics, we don't only look after children with sickle cell, but also children who have had severe malaria, especially these ones who have passed dark urine. And Kibuku and the Kibuku is not on this list because they had a number of challenges. They didn't allow indoor residual spraying, so they delayed, and as a result, there was a lot of complications. So with this, I want to emphasize that since Professor Omaswa is here, I would want to emphasize that health is made at home. It is only repaired in the hospital. So if children are having malaria, then as we go for barriers, let's advise people to use mosquito nets, to allow indoor residual spraying. And if the children are becoming anemic, then we have to emphasize that the children should be fed on, certain foods like millets and so on. And that is what we have gone back to, and it has played a big role in reducing this. I can't say we are 100%, but at least it's better. What is causing a problem now is that, again, we've run out of anti-malarials. Yeah, thank you so much.
Thank you. Dr. Assad, if you are seated in this room, you are needed down. Thank you. There was another concern on types of TB.
Thank you so much, Honorable. I normally like you so much in meetings because you are really... For the purpose of this meeting, I will tell you that let's know that there are majorly 2 types of TB for purposes of the meeting. The TB of the lungs, which we coin it as pulmonary tuberculosis. Then you were right. Then TB does not only affect the lungs, it can affect any other part of the body. And that one we are calling it extra pulmonary, outside the lungs. So any other part of your body can be affected by TB. That's why you are hearing TB of the bones, like you able said, of the intestines, TB of the liver. So every other organ can get TB. What you need to do is there are specific features you have. For example, high fevers, which we call evening, sometimes evening fevers, sometimes it is there all the time. Drenching night sweats, where people oversweat at night, loss of weight. So they may be as non-specific as that. But we appeal that when you're having anything unusual, you go to the health facility, because once a sample is picked, you can able to know. Some can easily be diagnosed by other things. For example, the x-rays, there are things we can look at, and we know that this person has TB. The scans and other things, apart from only the sputum for cases of extrapulmonary. Thank you so much.
Thank you, Dr. Enoch. Let me have something to say on the wage enhancement. Yes.
Yes, thank you. The chairperson, Busia, asked why Busia has continued to be having a low staffing level. It is very true. In the region, we have 2 districts that have low staffing levels, and Busia ranks top on the list. It has 51% according to the old structure, followed by Butaleja at 67%, as per our old staffing norms. And the cows in here could be aware that there was a ban on recruitment from Ministry of Public Service. However, currently, I need to report for the chief administrative officers who are here, those who have not heard that there is clearance to recruit, the circular is on, the PHROs are aware, and there is a platform for all PHROs in the region. When this clearance came, it was shared to all other PHROs. And what is it that we want to do? And the request is to the cows and the DHOs. We are requesting that let us make our recruitment plans ready, and then do the wage analysis, because this is a requirement from Ministry of Public Service that has to be submitted by 30th of September. It's a requirement for us to have adequate wage. However, there is clearance to recruit for all ministries, departments, and agencies. Thank you.
I think we still have 3 presentations, of which the Commissioner of Emergency Services will be presenting. I think the presenters to go back and take your seats. Thank you very much. We can clap for them. And then the next session, we shall request you to save us some time if we are to have the session of questions and answers. Because you are 3 and we have only 3 presentations. So there is a presentation on the private sector in supporting healthcare in Elgon region by Dr. Dickens. Is Dr. Dickens in the house? So you are welcome, and we request you to save us some time. Meanwhile, after that, the second presenter will be Ambulance and Referral Systems by the Commissioner, Ambulance Services, Dr. John Baptist Wanyai. Thank you. You are welcome.
Yeah, thank you so much, moderator. Some assistance. second, okay. Ladies and gentlemen, you allow me to follow the protocol which was laid yesterday. In your respective capacities, good morning. I'm Dr. Dickens. I'm a medical officer, and this morning I have the honor to share with you about the role of the private sector in enhancing health services delivery in Eastern region. Yes? Okay. Probably as it is loading, I want to also to have this honor to say that I'm really grateful to have this opportunity to present in front of my teachers and mentors, Professor Maswa. I'm really so much humbled to have this presentation before you. So going forward, as the slide is loading, are we able to? A moment. Okay. Okay, thank you. Yeah, so this is going to be our outline of our presentation. We're going to look at the background, the key achievements, the high impact areas, key challenges, and take-home messages. And basically what we are looking at this morning is the private, rather the public-private partnerships in health. As you are aware that PPP, what is it? This is any form of collaboration between the health sector, between the public health, between the public sector at any level, and this could be at national, it could be at international or donor agency, or even bilateral government donors, and the non-public sector, either public, commercial, or for profit, to jointly regulate, finance, implement the delivery of health services, could be products, or research, or education. And we see that a public-private partnership exists when members of the public sector join with members of the private sector in a pursuit of a common goal. And I want us to look at the Ugandan health structure. So the Ugandan health structure we see that composes of the private, the leading is the public facilities. Those are what we call usually government facilities. Then you have private. Now private has two arms. You have the private not-for-profit. Usually these are religious organizations, and then also have private for-profit, but also have another arm, the traditional and complementary medicine. And so based on surveys and opinions from community, it was observed that the private sector provides a considered private health sector many times is considered to have a wider client base, and is perceived also to offer a higher quality services in most areas. I think this we shall agree with me. I want us to look at what's the justification of the government engaging with the private sector in offering health services. One is that there is need to improve on the health sector output, both efficiency, and this is in line with achieving SDG number 3. As we know that you have to achieve the SDGs number 3 by 2030, and we are still lagging behind in our key performance indicators. Take maternal child health, babies are still dying, and this is not acceptable. And for us to achieve this, it has to be a combined effort of the public and the private sector. And that's why I'm really grateful for today's theme, and that's harnessing partnerships, and this is what we are talking about. The second is that we need to expand access to better and quality health care for our citizens in the country. And then also need to look at the opportunity to leverage the private investment And this includes financial and technical capacity in the private sector. There's a lot of capacity, there's a lot of resource in the private sector. I'll give you an example that in Eastern region, for the last so many years, it's just within about 2 to 3 years that we've been able to have a CT scan machine for the government in the regional referral hospital. But these services have been in the private sector. CHUA has been offering this for over 15 years. And these are the partnerships that we are talking about. Then there's also availability of potential partners for the government and as private sector matures. So there are potential partners that would want to urge to also embrace, come also in the private sector and be able to support them. This figure shows the workforce by sector. We also noticed that the private sector employs a number of healthcare providers. This ranging from specialists, as we can see. This was taken in 2015, but I guess is not very, very different from the current stand today. What are the key achievements in the key performance areas? We are going to, for the purpose of the discussion in this region, we shall have a bias to 1 or 2 private facilities in the region, and that is Mbale People's Hospital. We can see that through these partnerships, the public-private partnerships, we've been able to enhance on TB diagnosis and care services in the region. We've just been talking about TB, and the government, through various partners like Uganda Stop TB and the other implementing partners, have been able to access TB services, treatment and diagnosis. The other one is immunization. The government is supporting various private facilities in immunization. They provide the vaccines, they provide refrigerators, but also these private providers they pay the staffs, they give space, they take the care of the patients, they ensure also quality of the services being offered. The other area is the family planning. We have also the emergency services. We are aware of the emergency care. Most of these facilities have theaters, and it has hoped to decongest. We are talking about having 1 operating bed in the whole region, serving 16 districts and 1 city, 1 operating bed. This is very serious. And the only way we can do this is not crying to the government. We can sit here for the whole day. But if we have private investors who are going to come in and say, I'm putting up a theater which is affordable, of high quality, we shall clap hands and we shall be grateful. And this is what we are talking about. These are the partnerships that we want to come on board. Instead of talking of government, let's have different players on board and be able to support the health service delivery. What are the challenges that we face? A number of challenges faced by private care, healthcare providers. One, we have the capital. This investment is very expensive. We have unfavorable government policies. These range from high taxes, high interest rates. We also have high operational costs, high rate of staff turnover. These are some of the facilities in some of the private facilities that we have around. And this is doing a great work in supporting our patients. We have, what are some of the mitigation measures? What are some also of the asks that we talk about from the government? One is that we want a policy to be put in place so that the government can be able to scale up, seconding some critical staffs to some private facilities so that the care can be enhanced. We also have to ensure access of some of the essential drugs needed in management of these clients. We also need to expedite, we request the government to expedite the national insurance scheme, which is underway. We want this would be able to work more, to improve more in the service delivery, because most of these patients cannot afford the service, and yet the service quality, as we are aware, comes with some bit of cost. There's also need of representation of the private facilities at all levels of service delivery. All levels of decision making. Then also, if there will be through the commissioner, ambulance and emergency services, these facilities also, they have a form of referral network. So if there would be a way of enhancing or even having these ambulances stationed at some of the facilities so that it is able to be accessed by these other lower facilities, it will be of great concern. What are a few take-home messages? One is that the government still needs to develop a strategy in order to utilize the untapped resources and strengthen the private sector. Then to the private sector of late, we see that it has to be more innovative in order to meet the growing health needs. This comes in terms of technology and research. Then there has to be joint action at all levels, and I think this is what we are seeing, and I want to say a big thank you to the organizers of this UMA. As I wind up, there has also to be focus on improving on the quality of patient care. What we know is that this mind of being in private or government, it is in our mind as the healthcare providers. What a client wants, what a patient wants is a service. Once they come and you take away their headache, they are okay. They don't care whether you're a consultant, whether you're a nurse or a doctor in government or private. What they want is service. Also key, as I wind up, finally, key to note is that Mbale Hospital also, through these partnerships, worked with Uganda Voucher Plus activity, one of the projects, and it really contributed a lot in improving on the health services delivery in the region. I think, Commissioner, you are aware by then you are around as DHO, and we worked together so much in implementing this project. I want to say a big thank you, Commissioner. Doctor, I want to finally to thank the organizers and the team that funded and made this conference and assembly possible. Thank you so much.
Thank you, Dr. Dickens. I take this opportunity. I know there were so many questions about the ambulances, referrals. I take this opportunity to invite the Commissioner Ambulance Services, take us about the ambulance and referral system. Dr. Wanya John Baptist, you are welcome.
Thank you so much, our moderator. To our Professor Omaswa, you are most welcome, and all the senior colleagues in the House and the invited delegates here. Dr. Wanya John Baptist is my name, as outlined. Okay, we shall go through that, a few things. This is the period when, after approval of the policy, the Minister of Health guided that team, which is consisting of all the players, development partners, Ministry of Health officials, Office of the Prime Minister, the civil society, that how do we implement this policy going forward? This shows one of the big investments government made last year. We flagged off 116 emergency vehicles, which included road ambulances and command vehicles, which we distributed all over the country. I just wanted to update you that when we talk about the emergency medical services, we are covering about 4 areas. We are covering the response which must occur at the scene. Those are first responders. The first responder mechanism in this country is not well developed, but we are doing all we can to make sure that people receive the care they need to receive at the scene of an emergency. Transportation with care, this is quite well known. It is the one of the, which we are now calling the National Ambulance Service. Then at the health facility, the emergency care at the health facility is important. Do we have emergency units? Our casualty units, are they responsive? Are they following the standard processes so in order to save life? Then we also support the Office of the Prime Minister in disaster response. You saw just recently the collapse of that Chitezi landfill. In most cases, when the Office of the Prime Minister responds, you have seen Uganda Red Cross, you have seen Ministry of Health. We go there to provide first care to those who could have been affected. Now, WHO outlines the emergency care framework in those 3 areas: response at the scene, care during transportation, and at health facility level. If we have that full continuum of care, then we can improve patient outcomes. The government, from 2016, has prioritized the improvement of emergency care and referral system. Even in the new National Development Plan 4, the strategic direction is clear that we must improve emergency and the referral system. Now, as Minister of Health, we decided that the way of delivering the emergency medical service system is through a regionalized approach. And it is a 2-tier system where we have the central level, that is Ministry of Health, and the regional level. We have 16 health regions in the country which we are covering, and Mbale region, which you know very well, has the 3 regions of Bugisu, Bukedi, and Sebei. This separation is good for us because the first time when I did the distribution for the first 38 ambulances, when we said Mbale region, it seemed like it's only Mbale, but when they are broken out, people understand. And this region had received 8 out of the 38, and the parliamentarians were saying, why Mbale region receiving 8? They thought Mbale region, because I also come from Mbale, I had favored Mbale region. But when we broke it down to Bugisu, Bukedi, and Sebei, they realized that it was fair. Now this outline of the report tells you that constituencies, out of the 353 constituencies, we have covered only 104 constituencies. No, we have, yes, 104 constituencies. There's something which it is not well aligned, but we have covered 181 constituencies and the gap of 172. In total, we have a gap of 219 ambulances in the country. The average coverage is 51% from the needs. The needs, we have calculated them as constituency level, regional referral level, disaster response, then for highly infectious diseases, for air ambulance, and the medical command vehicles. We are also, in order to improve coordination, we are constructing call and dispatch centers. Here, I wanted to say, among the first 7, Mbale region is having 1 under funding from the World Bank. Also to bring to your attention that in the revised structure, the regions need to fill these structures to functionalize the emergency system. The medicine department, call and dispatch center, and also the aeromedical, particularly for Mbale. Other places have marine ambulance coverage. This is the district structure. Again, we ask you to prioritize and fill these structures to improve the emergency care, especially the structures at the General Hospital and Health Center 4. Now, This just outlines how emergency care is time sensitive. If somebody gets like a cardiac arrest, if you do not respond within 2 minutes, then the mortality goes nearer to 100% within 10 minutes. Then when you see there massive hemorrhage where you were discussing things of PPH, trauma and so on, 40 minutes you must intervene. If you don't do that, then towards 1 hour, we are towards 100% mortality. I wanted to tell you a few outputs from this year's performance. Patients who received care at the scene, in the reports we have, North Central was the highest, but Bukedi was the second highest. So we appreciate them for taking that step. But you see Bugisu is down there at 26.9%. So that means that we have not yet appreciated this. Bugisu is referring to Sebei and Bugisu sub-regions. But in the HMIS, those two are classified together. Now, health facility, arrival at a health facility using an ambulance. Again, we are not performing well. Bugisu is at 11.6%. Then Bukedi, where is Bukedi? They are at 10%, so they are next to each other. Then the number of patients who access care within 1 hour when they reach the health facility. This is what we put in the strategic plan. But ordinarily, from the time-sensitive data I've given you, you see that we are heading towards high mortality if we wait for 1 hour. You see Bugisu there is 80.4%, and Bukedi is 89.4%. That is response at the health facility level. Now, in terms of complications, again, Bugisu and Bukedi are number 2 in patients who get complications after care. Here, this road traffic injury rate, this region, it is not too high. We have Bukedi and we have Bugisu down the ladder. But we need, it could be the issue of reporting. Probably we are not reporting all what we need. When we did a midterm review of the EMS strategic plan, the percentage of death at the emergency unit has kept reducing from 1.9% to 1.49%. Maybe 2 minutes again. This is Mbale coverage with ambulances. You saw the LC5 of Busia giving that comment. Bugisu region, there are 8 ambulances here. You need more than that. I think Bukedi, about 10. Again, we need more. Sebei, 4 of them. In total, we have, out of the required 45 for constituencies, we have only 21. So the gap, you have got to note that it is due to the amount, the number of ambulances we have. Most referrals were obstetrics and gyne, and mainly I see there Bududa is leading in the referred cases. Referral is a good way of management, but then when you refer a lot, then we have got to go back and look, is the hospital or health center for functioning well? Internationally, the ambulance response time should be 18 minutes. In our AMS strategy, we use the golden hour of the surgeons of 1 hour. But from the survival, when you take 1 hour, it is risky. Mbale region ranges between 20 minutes and 1 hour from Dr. Bruno's report. The emergency unit has limited staffing. That is why I made that appeal. And these are responses to disasters which occur in this region. Here we are looking at what is working. The regional EMS coordinators help us to perform. Coordination of emergency response on social platform has also helped. Fuel cards, which will be discussed. Some places, administrators have the fuel cards and they are not accessible to the ambulance drivers or providers when they need them. We need also in advocacy with partners to put in more into the health system. Those are some of the things: recruitment, EMS reporting on the data, the deficit in ambulances, ambulance misuse. These are recommendations which I've largely mentioned. Yeah, I want to end there. Thank you so much.
Thank you, Commissioner Ambulance Services. We have our last presenter, and we shall beg maybe whether he will compress the presentation in 5 minutes, because time has left us. We have a voice for the people, and he's going to present the community. This is Dr. Wabloko Dominic. Dr. Dominic, you are welcome.
Yes, thank you, Melda. For the community, you have to be patient a bit. You can't rush the community. Protocol observed. I want to share with you something about the community. You are also the community, but you are you are a community, but you are the custodian of health. When you look at this slide, look at this picture, you realize that, as Dr. Beso said, health is made at home, prepared in the hospital. So you can see that family represents a unit of a community. So we can have families like this, then we shall not have any problems. We maintain our discussions of the theme, harnessing and building resilient health system. This will be based on the good practices linked on our past experiences, and then we come up with what works. Just a flash to show you the outline of what we shall go through. Yeah, before, as a community, first thing is, where are we located in the region? This is the map of the region, and you will see that, you will see that the sub-region are 3. Sebei is on the extreme east, covering the north, and it neighbors our Kenyans, and Siberians have had a lot of problems, which problems have always spilled over to all of us, even up to the national level. We have had, for health purposes, we have had the outbreaks, polio. We have had polio outbreaks because of our neighbors, the Pokotos. The Pokotos have always had cattle raids, actually taking the wealth of the Siberians. Then the Bugisu is in the middle, it's the anchoring Sebei, and then Bukedi. And you know, Bugisu is where the city is. It is a mix of all these populations who are coming in the city. It is in the main route from Mombasa to Sudan. So all what it brings, we long truck drivers, think of HIV and the rest. Then down we have Bukedi. So that is our position. Then how many are we? How many are we? When you look at on the left, we are about 4.5. This is a very high population. 10 years ago, we were about 4.2 or 4.3. And you can see the graphs is showing Buked leading with about 2.4. And then Bugisu, 1.8. And then Sebei, 300 something. This is a big population. And it translates in so many things. All our indicators, when you look at our fertility rate, it's about 4.2. That has come down, but we are still at a high fertility rate. When you look at our pregnancy rates, at 22%. When you look at our birth rates, it's high. When we did domestic per capita, doctor per capita ratio, it was so high. In the whole region, we were the last, almost the last. When you look at the doctor, midwife, or nurse population ratio, we are really the last. And you know the population is increasing. This is just an overview. And then about the organization structure. On an overview, we are just looking at who are we, the community. We define ourselves as people living together in the same region. We live together, but we have things in common. There are things we share: knowledge, beliefs, customs, religion. And these are things which make us, give us a culture. And a culture is what makes the ingredients of the community. And to us as health, culture is very, very important. One, because culture is second to environment in causing disease. Culture influences so many things. Then on the right, just give you a picture of leadership in the cultural institutions. This is basically about health because the organigram is so elaborate. But this is how the institutions implement their health activities. They have one, the king, and then the 2 ministers, and then the advisor on health. I'm the advisor, senior advisor of health to the cultural institutions. And I want to take this opportunity to introduce our Minister of Health in the cultural system, Dr. Namomi. She's here. She's our senior physician working with Bank of Uganda. Yesterday she was here as a partner donating mattresses to the communities of Lambuli. Can you stand up? Today she's here in her capacity as the Minister of Health for the cultural institutions. Yeah, these are the ones who make the two ministers, the Minister of Culture and the Minister of Health. She's in charge of training about 1,300 local surgeons of our community. Yeah, when we talk about culture, we are looking at the implications. We are looking at the implications, the positive and the negatives. But, you know, when you are, we shall start with the negatives. This thing is, yeah, we shall start with the negatives because this is what really matters to us as health. That the negatives, we have had breastfeeding as a culture. And when these babies are enough, we shall have problems with malnutrition. And we find that actually the indicators for malnutrition in our region is very high. In the past, we have had circumcision and we have been accused of spreading HIV. because of unprotected sex. Usually whenever there is circumcision, there's a lot of sex going on. And our local surgeons were using one knife for so many people. Rape cases have been reported. We have about 2 this time reported at the cultural site at Mtoto. We have had a lot of excessive alcohol and drug abuse during our ceremonies, and this one lead to some disease. We have had a lot of early marriages as a culture because of maybe dowry, people benefiting from dowry. We have had family planning discouraged, the contraceptives, like Catholic Church doesn't believe in contraceptives. They prefer natural methods, which are really not practical. We have also had politics in our communities, and it has really, culture is supposed to be non-partisan, neutral, but there's a lot of politicking in our culture system. And I can bear this, that when we had programs like cholera, politicians come in and they start protecting the people you have some kind of arrested, and they say these are our voters. When we had polio, at the first time, there was a lot of resistance from the community. And this was basically, it was politics. And then, of course, you remember COVID. When we had COVID, the first round, people were saying, no, it's not for us. These people are just trying to do this. Second round is when people believed. Seeing is believing. That's when they believed that it's true there was COVID. But initially, it was just politics. Use of traditional medicine is our culture, and this has really affected us. We have so many maternal deaths, rupture of the uterus, because of these herbs they use. The doses, I think, they are too strong, and they have caused us all this. Culture has also promoted a lot of myths about the cause of disease. If you die suddenly, they will say, I think you must have been bewitched. There's something behind this. We have so many people dying out of pulmonary embolism, heart failure, and people don't look there. They say they have bewitched you. The Bagwere says, omuntu afa bulwire tafa omuntu afa bulwire. For them, they believe you cannot die of disease, but you die. It's because of maybe some kind of witchcraft. We have had domestic violence in the Bugisu land here, and you'll find that for us, we believe that if you don't beat a woman, it means you don't love her, that kind of thing. It is still on. We have had widow inheritance is very common, especially if you die and you have some wealth. If you die and you have paid dowry, the family members would want to keep the wife. Lifestyle, we have had a lot of lifestyle. Obesity is a disease, and people think you are doing well, you have money, that's why you are putting a lot of weight, that kind of thing. Female genital mutilation, yeah, it used to be there, but I think it's no more. But right now, we find that they take people to Pokoto. Pokoto still mutilate ladies. So our people from Sebei are taking the other side, mutilated, then they are brought back. So constitutionally, it was banned, and if they find you, you can, but it's still going on in small pockets. Now, that was the negatives. So the good things which are positive are really that, yeah, I looked at circumcision being the biggest culture in the region. That circumcision is good, and for you, if you are a boy, to be initiated into manhood, that time is very, very critical. They initiate you to take up responsibilities, physical, mind, and then your social being. So to us, it's a very good thing of initiating someone into adult. Circumcision is hygienic. Yeah, even WHO. And the circumcision we're talking about is safe circumcision. We are no longer practicing crude circumcision. It is safe. and even WHO recommends it, that it is safe. It offers some protection. If you remove that foreskin is very dirty. If you remove it, you will prevent so many diseases. Actually, research has shown that the people who are circumcised, to a certain percentage, like 20%, they are protected. Because the foreskin you are removing, it has cells called Langerhans cells, which are a culture media, which the virus likes so much. But of course, we don't tell these research findings to our people. We tell them, please don't use a condom. We have used this culture, circumcision, as an entry point. Whenever we want to mobilize our people for any program, health program, we mobilize them and go on. Prompt breastfeeding is still on. Some families really practice prompt breastfeeding, and we really promote it. Our institution is mobilizing the communities to respond to these outbreaks. It has been so good. So, amidst negatives, the cultural institutions have come up to do something, some of the interventions. And the number one is HIV prevention and reduction. Recently at Mutoto, we had the full-fledged medical services. We all there, family planning, HIV testing, TB, they were all there at the site. We trained the local surgeons. Those were the problem, actually. One knife for so many, but now one knife for one candidate. So to train them about sterility and other things. And after circumcision, these local surgeons, we use them to make sure that they carry on the message of HIV. There's that time when after circumcising, the local surgeon comes and starts those initiations, briefing you, handing you instruments of manhood, and those are the messages that please avoid refrain sex. The institution has, the institution has, yeah, I think because of time, let me stop there, but thank our partners who have been here with us. Thank you.
Thank you very much, Dr. Wabroko, about the voice of the people and the institution. We have failed to manage that time, the presenters, most of us, and we have entered into our time for questions and answers, and even encroached on the time for tea. So I'm requesting the Master of Ceremony, if you are around, to come and show us the next steps. Meanwhile, I want to thank all the presenters for the work well done, and also the participants for the active participation. Thank you very much.
A round of applause to all the people who presented. They really took time to prepare, research, and I'm sure that these PowerPoint presentations will be shared with us. I'm also very happy to see and honor Professor Maswa. Professor, can you stand up and we clap for you and honor you for all the work that you've done in the field. Professor Maswa will be speaking with us. I now want to invite you for a cup of coffee so that we can come back and try to buy time. Our target is at least we need to be done by 1:30 tops. I invite you for coffee right outside. Karibu. All right. I'm hoping that everyone has grabbed a cup of coffee. I would love to request those that are still having coffee to come in with their coffee so that we can try to beat the time. We have strictly 1 hour here, and it's 2 minutes after midday. 5 minutes actually. So may I invite people who are outside to come in with their coffee, please. Shortly we will hear a keynote from Professor Omaswa, who will take 10 minutes, after which we will have a panel discussion, which will take strictly 25 minutes. After that, we will get into the closing session. May I now request the backing team to help me mobilize people back into the room so that we can save on time. They can come in with their coffee or teas, and we can try to do things simultaneously. Okay. The technical team, I hope Professor Maswa's presentation is ready. And then, yeah, let me just, okay, great. All right. Let me just bring people into the room, then we can start. Thank you. A very good afternoon. Welcome back from the previous breakaway sessions. I would love now to call this house to order. Can we please take our seats? I've been notified that about 30 people did not get breakfast. We are fixing that. And as and when it's ready, we will inform you to go and pick a cup of coffee. Please have a seat, kindly. Enoch, help me sit people down, please. Thank you. This afternoon, dear Assembly, we are privileged to have Professor Maswa, who has served this country in different capacities, and we are honored that he's here with us to share his thoughts on harnessing partnerships for improving our health sector. Ladies and gentlemen, may we stand up and honor Professor Maswa as he comes to give his keynote address. Professor Maswa, you're welcome. Yes, if you press this one, it points, yes.
Good afternoon, ladies and gentlemen. It is a pleasure to be able to come and converse with you. I should have come yesterday, but there were other commitments which did not make that possible. And I'm so delighted to see so many district leaders here. They are really key players on this agenda. I have had some interactions with some of the districts. I was speaking with the people of Manafa. There. Okay. I interacted with the leadership of Manafa some months ago. I also, I think about a year or two ago, I was doing some work with the people of Busia in community health. And of course, Mbale here is like home to me. So I have been given just 15 minutes. I had prepared to speak for 20, but that is okay. We should be able to do that. That is the structure of the presentation. Health is a very high-ranking priority. I hope we'll convince ourselves on that. What are health systems, the key role of leadership, the partnership between individuals and communities and government, and then the leadership role of the Regional Referral Hospital. So that is like my Africa, the one which I have seen. I'm probably the oldest person in this room, without any doubt at all. We went from colonial times to independence, very hopeful that we in Africa would be able to catch up with the rest. We got independence, we did well early, but then things went wrong. Here in Uganda, we say it was because of Idi Amin, but forget, these other countries didn't have Idi Amin's, Kenya, Tanzania. Their indices are not different from ours. The whole of Africa went through a big problem at that time. Particularly, the Cold War was mainly responsible for it. But things are looking better now. Things are looking better now for Africa. That Cold War is weaker, there is more democracy. The African Union has moved from OAU, which was fighting for independence, to AU, which is more about people. So things are looking better today than they looked like 20 years ago. And these are some of our problems. This context is very important indeed. We are still poor. The population is just overwhelming the social services. I went to school, my P1 class, we were 11 children in the class. Now they are in hundreds in the same room. We were 11. And health facilities, the same thing. Then there's a big dependency, a lot of young people who have to be carried by the rest of us. And the one about the attitude is very, very important indeed. I don't know. Does it show? Doesn't. The second one from the bottom. People giving up, you know, what can I do? This is Uganda, what do you expect? That type of thing. And then things are not right, and we live with them. You go to a health facility, there are no health workers, you shrug your shoulders, and you go and look for a solution somewhere else, instead of going to the chairman of the district or the RDC and banging on his table and say, what is going on here? The demand side is very, very weak. And that is part of the issues that we are talking about today on partnerships. And of course, that is Africa doing very badly compared with Southeast Asia. Then those are the child mortality rates. And the line at the top is for the African region. You see how big the gap is between us and the other regions of the world. Why is that? Are we ashamed of that? Do we feel that pain of being lagging behind other parts of the world? And this is really the message, number one, that I want to share. There are two messages. This is the first one. We individually and collectively must feel uncomfortable, feel pain, be ashamed if we are not performing and providing the services that we are expected to deliver to our people. If we don't feel that pain, that anger, we will not have what it takes to put things right. So we get elected to these offices, we get appointed to these offices, and then we just sit there and not bother about achieving what we are supposed to achieve. That's really a very important message. Until we care, very little is going to change. This statement is a quotation from a participatory poverty study which was carried out here in Uganda in the year 2002. Rural people were being asked about their quality of life. And that is a quotation from one of them. When I fall sick, I just remain like that, like an animal. And we've got to a state when we accept things which we shouldn't accept. When people die early, we say, well, this day has come. A child dies of malaria, say, God called that child. God didn't call the child. It is we who are saying that, making those speeches in the funeral, who should have stopped that death from taking place. So this really, everything that we are talking about starts here, as being, taking our life seriously. This also is our people. This, that same study I told you about, asking rural people what causes their poverty, and health is regarded by the people as the topmost, the cause as well as the effect of poverty. So health is everything. If you don't have health, you can't enjoy life, you can't use your money, you can't earn money, you can't. So health, 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 health. is our #1 priority. Also this message is important. When I was Director General in the Ministry of Health, every year we would go to the Ministry of Finance to ask for money for the annual budget. And they had classified the ministries in two sectors, two categories: productive sectors and consumptive sectors. And can you imagine that health and education were classified as consumptive sectors, which is being part of the cause of our problem. Those economists classifying health as non-productive, as just a cost. And that went on for a long time, but that has now changed. That has changed. There is this man here, Paul Collier. He was working for the World Bank as the chief economist of the World Bank when I was working in the Ministry of Health. He used to come here to Uganda, and he wrote a page in the New Vision one time saying that the health sector in Uganda was a bottomless pit. But he has changed his mind. This is now, through various studies, health is regarded as not a cost, but an investment, which gives you back. You invest $1, you get back 9. That message is extremely important indeed. And then, of course, COVID. You all remember COVID. It is not too far away. It brought the world to a standstill. And you needed strong health systems, resilient health systems, to get on top of COVID, prevent your people from perishing, and getting your economy to run again. So this is a photograph of myself and that gentleman who said the health ministry was a bottomless pit. By now, he had changed his mind and said for 40 years they were teaching wrong economics of profit. But what do you do with the profit? What about the people who gave you the profit? So social accountability was very weak. So I thanked him. It was in a meeting in Germany where he told the meeting that message. And then I went to him and introduced myself. And he told me to read his book. You get that book, The Future of Capitalism. It's really what matters in the life of people. What matters? What really matters is their health, their peace, and their ability to earn basic conditions for clean living. So that is what we should focus on. So health is high priority. Health is top priority. And it is you people to make it possible for people to achieve their health. So, and it is possible to get good health at low cost. Some countries have been able to achieve this, even with the resources in Uganda today. I will be telling you in a moment that we can achieve good health. Thailand, for example, Sri Lanka, even Ethiopia is listed there as countries who have achieved good health at low cost. And this is what you need, political commitment to health as a social goal. And that's why you, the chairpersons who are here, the RDCs who are here, and of course all of us, we should put health as a political, social priority. Then values of equity, not caring when people need help, and then education, especially education of women and linkages between sectors. Growing up in colonial times here in Uganda, they had chiefs, these local chiefs there. Those people governed the communities comprehensively. They are the people who would come, complain if your home is not swept, if you don't have a pit latrine, if you have not gone for vaccination. my smallpox vaccination, that man came with his bell to our home just here in Ngora. Say, everyone has gone for smallpox vaccination. What are you people doing here? So I would like to encourage you to get those parish chiefs to be health workers, to prioritize health, so that health is part of governance of society. And then, of course, we have people from the Ministry of Health here, Dr. Wanyage and Driwale. I would like the Ministry of Health to have a balance between health promotion and medical care. Health promotion should be the higher priority. But for various reasons, the whole world, most people see the Ministry of Health as a disease-curing institution and not a health-promoting institution. Can we do that? And in the districts, we can do that too. We have mandates to do that. There are DHOs here, isn't it? I hope you are listening, and the RDCs. Alma Ata basically said it is possible to achieve good health with resources which are available. And then we have SDGs now, and we have very ambitious targets, but we are not achieving them. We are lagging behind. And last September, I was invited as the speaker at the UN General Assembly on primary health care. And what I came away with was that we know what to do. We know what to do, but we are not doing what we know what to do. So SDGs are an opportunity which we should use. So now, in Busia district, we did a community health program there. In Busia, Muru, Ngora, Mukono. And also during COVID, I was chair of the, I think that's my phone, just ignore it. I'll switch it off. I was chair during COVID of the Community Engagement Committee of the National Task Force. And during the studies before COVID in those 4 districts, we worked with VHTs, we equipped them, we paid them some allowances, and within just 6 months from the initiation of support to VHTs, with tools for working and allowances, going to every household. This is Omaswa's home. He has got high blood pressure or diabetes. His wife is pregnant. Where is she going to deliver? Things change so very quickly. And these are some of the changes which took place in terms of antenatal attendances, skilled deliveries, immunization. It happens very quickly. That was the last one was Ngora. This is Mukono with the immunization and family planning. So we know what to do. And those are households in Amuru. You see how clean they are. So basically, if we empower communities through what I would recommend, village health committees, which are chaired by LC1, for example, together with the Secretary for Women and maybe Defense and the VHTs and NGOs. They meet every month and they talk about what it is that is affecting the health of their people. And they find the solutions themselves. All those issues, some of those villages say we don't have teenage pregnancies in our village because the communities are organized. So my message here is that let's focus on community health systems. And you can do that in your districts. You have the powers to do that. It will achieve SDGs much quicker and affordably than anything else. Okay, someone connected this statement with me. Glad that you remember I was the one who originated it. Those of you who are old enough. And this is quite literally what it is. Health is made where people live, and people are personally responsible for their health. There is another talk I give called Health is Your Own Responsibility. We are born healthy, our bodies are trained to be healthy. Let's obey our bodies. Let's be responsible for the health of ourselves and the people we care for. And, you know, we won't need health services. So this is now on governance. This is a book which we wrote. I co-edited it with that white lady there, called A Handbook for Health Ministers. Following a study, we carried a global study. What do ministers of health need and their ministries to do their jobs better? And these are some of the things which are in that book. So the Minister of Health is in red in the middle. His boss or her boss, the president, is up. There is parliament. But in the oval there, you can see other institutions which are in the country, which the government needs to deal with. They are like the universities, like NGOs, like the donors, like CSOs, and so on, the private sector. So you need to bring all this together in order to have all of government and all of society. And the job of the Minister of Health is to do this. And the ministers of health here are you people, the chairpersons, the CAOs, the RDCs, and the DHOs. You are the health leaders in your districts. What you need to do is to bring together all the actors, and I'll tell you how to do that in a moment. So that's a health system. It's very broad. These are also building blocks. WHO has 6 of them, but the 2 most important ones are leadership and governance and a health workforce. Once you have those fixed, everything will be okay. And it is the government, you know, the government, we tell people, vote for us, we'll do this for you, this. So all over the world, it's known that governments are responsible for the health of their people, planning for it, making it happen right. And this is a triangle which moves mountains. I got it from Thailand. We need a combination between knowledge generators, because you have a university here in the region. Is Busitema? I think, is Busitema here? Okay, and other academic institutions, even the Regional Referral Hospital, you should be able to do research, generate knowledge, which supports the needs of the people. Then between you, with your knowledge and the society, you take this to the politicians, and they will just have to support you. Otherwise, they don't get votes. So it is possible for society to use knowledge, work together with academic institutions, and solve problems together with the politicians. But you need a critical mass of individuals in the place who are committed, who care. How can we get this culture among our people? And we have to build trust between the partners through openness, mutual respect. And trust is very difficult to build. It takes time, that it's very easy to break. In one day, it is gone, what you have built over years. So this is how to make big plans, political commitment, health as economic values, involve all stakeholders, and legalize what you decide to do so that you can enforce it. This slide is basically to say that We are decentralized. We have powers under decentralization, and we can do a lot. But there is now worry that decentralization is becoming a problem to Uganda rather than the solution that it was envisioned to be. And this is in your hands as district leaders to deal with. Along the way in Uganda, we had a minimum package of services which was provided. Cost sharing was abolished, and we also introduced total quality management, and things did start to change. Financing, my message here is that we should develop a package. We have a minimum package already, and implement that through the tax base. And then for what is outside that, we have the National Health Insurance Scheme. So we all should campaign for the National Health Insurance Scheme. The sooner it comes, the better. And it may be difficult to start, but let's start. We make mistakes and learn. I think I've said that already. This is for you, Dr. Driwale, for health workers. These are the competencies that you require in them. Because health workforce, please look after those people very well. Without them being happy, you are not going to achieve what you want to do. They should be able to work where they are needed and achieve the most with available resources. Not complaining all the time, I don't have a CT scan and what and so on. Because just with your 5 senses, your touch, your sight, your hearing, you can make most of the diagnosis correctly. The doctors here are listening, I hope. Don't get dragged into that business of asking for investigations which are long and costly. Talk to the patient, examine the patient. You will make most of your diagnosis and treat the patients. When I say this in America, they clap because they are now, because they are very sick. They don't talk to the patients. They just send them to the laboratories and investigations. Which is very bad. Quality assurance is important. We taught quality assurance, and I think you people in the ministry, you have a department. Let all the district leaders get taught the basic quality improvement approaches. And also here at the bottom, I say the Constitution of Uganda states that the state shall take all practical measures to ensure provision of basic medical services to the population. So we are entitled to this from our Constitution. Monitoring and evaluation. Support supervision is important to talk about. Supervision is very important. All of us need to know that someone may find out if we misbehave. It helps people to behave right. So, but when you supervise people, don't intimidate them. Become their friend, and they trust you, they open up to you, and then you can show them what to do, what they are doing right. That supportive supervision needs to be taught the correct way. So this is Mbale now. Dr. Bo, here you are. Managing institutions, there are just a few things I have learned from my own experience. Number one is to build trust of the people you work with. And you do that through structures. You have committees, you have task forces. Make sure they meet and they are open. They should be free to say what they want, not to go and grumble behind the meetings and backbite each other and so on. So openness and transparency. So those structures should be there. And then also I talked about the importance of community health systems. You have your community health department, and there is an officer in it. Make sure that it is funded, it is working well, and links with the districts. Also engage the Ministry of Health people. If they don't come to the region, ask them why not. Because I went to some of the districts, those 4 I told you about. The supervision visits from the center are very few. Yet we used to go to every district every quarter. We would spend a week in every district. There were fewer districts, but anyway, the country has not grown in size. It's just subdivided. We can still find a way of engaging the districts. And also the health development partners, let's implement the 3 1s. In some of the districts, the district health plan is not supported by partners. They have their own programs. There should be only 1 district health plan. And all the resources can come from different sources, but there should be only 1 plan. And the district implements, and then you monitor together with the development partners using that 3 1s. So this is a great meeting. I'm very happy that you are doing this. Be open, like I heard you being open to each other here, and get solutions and implement those solutions and meet again and meet again and meet again. Your people may be able to achieve the health services that they deserve with your leadership, and also hold the central government to account, your members of parliament and so on. And Uganda, there's very good policies, but we don't implement them to scale. This is another topic, basically suggesting that we should make a new beginning for health in Uganda. Let's have a process to enact a new health act. I think it's being done now, but it should be having meetings like this across the country to consult about what should go into the new health act. And then let's have the health insurance scheme. And then to get anything to happen, you need the politicians to be together with the people, so that we move with one vision, the whole of government, the whole of society, and we can achieve good health if we are as organized as this. So what to do is known. I'll leave these slides behind, and maybe we can even write about it and share it in another way. This is another message. Capacity grows from what is there already. Don't start as if you have been doing nothing before. Just move with what you have and be practical. We need to support everyone. Expand locally driven research, strengthen management and leadership, sharing information, moving together like you are doing here. And I just end by my second message. I told you there were 2 messages. The other one was about pain and shame when things are not right where you are. Then this one is about we, and as individuals and collectively, being the leaders. If you are a leader, please be a leader. Make those things happen for which you are being the leader. And if it is not now, then when will you do it? If it's not here, then where? Then, you know, some years ago, I came from abroad to work in that Ngora hospital. My home is near there. And things were going wrong all the time. And people just laughed. But why are you laughing? Oh, say, doctor, don't you know this is Uganda? What do you expect? But then I didn't give up. Said, I want to convert this into a place where we say, this is Ngora Hospital. We expect only the best. And this is what I would like you to say about each of your districts. This is Namisindwa, this is Manafa, this is where we expect only the best. There is no nonsense here. So all the best. Congratulations on convening the meeting, and make some resolutions which you can follow up and make this one of the most healthy regions of Uganda. Thank you.
Can we appreciate Professor Maswa? We celebrate you. We are really grateful for the time that you've served us as a country. Thank you very much for coming, and thank you for these great remarks. Our time, like I'd promised you, we would end by 1, but I would request that I buy extra 30 minutes. Dr. Watiti, I'll give you 5 minutes to make a few remarks, and then we can get into our panel discussion. You're very welcome, Doctor.
Thank you very much. I am used to this. One time I was invited to talk to judges, and when I started, the judge who introduced me started by introducing me as a self-confessed, world-renowned AIDS victim. And then he had been given 30 minutes, but when I started, they sent me a paper to speak for 5 minutes because the group was a bit hostile. So I started by doing what I am going to do, by giving them my number. So get your pens. 0772 63 84 66. 0772 63 84 66. What is interesting is that I spoke for about 3 minutes, and that night, about 10 of those judges called me, and we became very good friends. So my name is Dr. Stephen Watiti. I'm a Mugiswa. I come from Mbale, so Mlembe Bach Masaba. Very good. I married from Teso, so Yalamanwe. I am here to talk about advocacy, and I'm happy to be speaking in front of the leaders of this place. As you know, I have been the board chair for Mbale Regional Referral Hospital for the last 3 years, but luckily, my term was renewed, so you are stuck with him for another 3 years. But I'm also a commissioner with Uganda AIDS Commission. I was picked by the president to be one of the commissioners, to be able to end AIDS by 2030. So I am very passionate about that. So I'll be talking about HIV and the role of leadership and especially advocacy. Advocacy means speaking out. Speaking out means opening your mouth and saying what you are supposed to say. And now I ended this because in 1999, I was very sick. I had TB. I've suffered from TB about 5 times, including what they call MDR TB, but it got cured, so it's cured. I also had cancer. I'm a cancer survivor. I had what they call Kaposi sarcoma. I heard about Kaposi sarcoma from Professor Olwen, he was our teacher. I did not know that I was going to die of the same disease. I've also suffered from cryptococcal meningitis. Cryptococcal meningitis, I don't know I have a name for it in Lugisu, but in Baganda call it Mulalama. So in 1999, I was taken back to Mulago where I trained as a doctor to deliver health for all by the year 2000. As you know, our slogan by WHO then was. But I was dying. I had TB, MDR TB. I had cancer, cryptococcal meningitis. So I was going to die. And there was no treatment. There were no ARVs. There were no programs like this. But I didn't die. That's why I'm here this afternoon. And I read the Bible. One morning when I was very sick, a woman came to visit me, and she held my hand. And she said, Dr. Watiti, I was praying for you last night. She was in locally. I couldn't talk, but I could hear. She squeezed my hand. She was a very good clinician. She squeezed my hand and squeezed back. So she knew I was listening. And she told me that God had given her a verse for me from Psalms 118, verse 17. Now that verse says, I will not die, but I'll live. The second part of that verse says, I'll talk about the good things great things that God has done for me. So I started talking, but because I had cryptococcal meningitis, they thought I had gone off. But whenever they sedated me, whenever I wake up, I would talk. Long story short, I'm here. I'm HIV positive. I've lived with HIV for over 35 years. I've been on ARVs since 1999. I started taking ARVs when they're costing $500 a month from black market. Now I take one pill every day. My viral load is suppressed, so I'm among those who is suppressing. I check for cancer every year, and I'm cancer-free. I don't have cryptococcal meningitis. I'm healthy. I'm, I think, the second oldest person in this room because last birthday I turned 71. And I published a book on aging called Aging Gracefully with HIV, which I want all of you, especially people who are in HIV work, to read. Earlier on, while working at Mbale, I noticed that a lot of my patients were very traumatized. And so I wrote another book called Conquering HIV, my personal experience of living with HIV. These books are in bookshops, but people don't read them. These ones are from my friend from Sironko. The cow from Sironko, I saw him here for the first time, so I gave him these ones. Mr. Kelly, yes, so you can have this one, but the rest of you will buy. Now, advocacy. I would like all of you, the RDCs, the chairman, the cows, the whole system, all hands on board, to ensure that you speak health to everybody. Health is the only asset that a person has that is worth talking about, not wealth. I'm not saying don't talk about wealth. There is wealth creation. But the real wealth we have is our health. So I want you to do that. I want you to utilize the services. Advocate for the services in your place. For example, HIV testing. All our health centers, whenever I go there, I check, they can test for HIV. Sometimes they have no kits, but because they're being used up, and there are other places. And I know, I always call Dr. Wangisi, and he tells me, no, they may not be in Bufumbo, but they're in what? In Busiu. So let's utilize this. Let's talk about HIV. We would like to end HIV by 2030. Actually, before that, we have the tools, we have everything. There is no reason why somebody should get infected with HIV in this region at this time. And there is no reason why any person should die of AIDS in Uganda today, in Mbale today, with these people. When I started taking ARVs, I was swallowing about 13 tablets. It was like eating nuts. Now we have one pill a day, and there are even injections coming. So we can stop this. We are working to set up a cancer center. I hope some of you know this. Instead of people going to Kampala, we want them to do, but the cancer center, we don't have to cure. The main reason why I got cured of cancer is because it was found early. In Uganda here, most people who are diagnosed with cancer will die in the next 3 years, if not earlier. Yesterday I was called by a very important person from this area. I'm finishing. He's in Kampala with stage 4 cancer. And she said she has refused to be taken for chemotherapy because she thinks she won't die. So I told her, you send Kampala, and after this meeting, I'm rushing back to talk to her. I want to use my experience of having escaped cancer that hope we can help her. But cancer is fairly well spread. In fact, cancer, diabetes, and high blood pressure are going to be more problematic to us than even HIV. The most likely cause of death among you is not going to be HIV. And I'm talking to you, the RDC, the chairman, even the DHO. Let me tell you this. In 1984, when we graduated, we were about 90 doctors from Makerere. 20 years later, when we met, one of us was a professor, another one was a commissioner in the Ministry of Health, but 20 of us had died. 20 doctors, they died of HIV, not HIV. But what killed these younger doctors? I was the oldest in the class, I think. So let's watch our backs. Let's go and know our cancer status. Yesterday, like we have been telling people, know your HIV status. I have a feeling that people with cancer here, but they don't know because you have not checked. So these are the things you should be talking about. Lastly, palliative care. What's palliative care? It's a form of, and I learned about this when I was very sick with cancer, TB and meningitis. I was referred downwards to nurses, palliative care nurses. And they came and counseled me, put me on treatment, prescribed morphine for me. I didn't take morphine for 2 days because I feared getting it. Then they came back and counseled me. I took morphine, and for the first time I slept in a month. I even started taking the ARVs. The bakisose na paka humaru, you know? Paka humaru, you know, you understand? It's like shaking your head. So, oh, that was close. So friends, I think this may be the most important meeting you have had in your life. And listen to me, and listen well, because sometimes I close my eyes and talk like a dying man. Because I'm the only one in this room who has almost died. My mother used to call me Wolayo. Wolayo means a person who died but came back. So I died because with crypto, with cancer, with the TB, all of them three, and I recovered. So listen to me and listen well. If we don't do these things, we are not going to do well. But I pray we do well. We know what to do with cancer. I've told you. We know what to do with HIV. I've told you. We need to talk about palliative care. Is Sister Esther here? Esther Tucker? She should be here. But Esther Tucker runs a small fledgling unit at the hospital called Palliative Care Unit. I asked Dr. Obo whether we have a budget for it. But he said, well, we assume, he was keggy, so most likely there's no package. But palliative care is that service that you need. It's like a parachute, which you need to land well. If you don't have it, you will not need it because you will have landed then you will not need a parachute. Let me tell you, we all need it. As you grow older, you know this. My mom died recently at 93. And she had to use Pampers. My mother was strong, but she went well. I thank you. I've taken long, but I've given you my number. RDCs, I know you have airtime. I want you to utilize me. But utilize your DHOs. Give them information. Health education is what's going to empower people to make healthy, informed decisions about their health and that of our community. We can complain about the hospital, and I receive a lot of calls. Complain about ambulances. But surely when you see a woman who needs an ambulance when it's obstetric, but she has been pregnant for 9 months, what did you do before? Did you talk to her about preparing? How do you expect to come and find what? An operating when it is not there? You have never been even there. I could go on and go on, but I thank you. I'm not quarreling. I'm just doing advocacy. And with advocacy, sometimes you step on people's toes, but it works. One time a man called Abraham almost saved the whole city using numbers, advocating for Sodom and Gomorrah with what? With God. Jesus one time saved a woman who was going to be stoned by advocating for her, spoke for her. I hope I've spoken for somebody. I thank you.
Ladies and gentlemen, Dr. Watiti. Let's love on him once again. It's difficult to talk to doctors and medical personnel about these things, because they're the ones in hospitals. But I saw the level of attention in the room when Dr. Watiti was here. Literally, even the doctors themselves. I saw Dr. Imelda like, okay. Thank you very much, Dr. Stephen Watiti, my very good friend in the advocacy space. Can we stand up and stretch a bit? Health break. Okay. Who can give us a stretching thing? Anyone good with stretches and... Okay, can we breathe in like this? Breathe out. Breathe in. Breathe out. In the last one, the person who breathes in last, breathes out last, will sit down last. Okay? We go. Breathe in. Dr. Diwali. Thank you very much. Hey, we still have people standing. Thank you very much. We're going into the last panel. We have about 25 minutes before we can conclude this. So, Professor Maso, you're not here yesterday, but we divided ourselves into different groups here, including the group that had RDCs, cows, the medical practitioners, as well as the district. Yes. Okay. I had requested Dr. Agri to facilitate this, but then he told me I will be biased. So I have taken back the opportunity of moderating. So I would request the different group members for the people who you selected to represent you to please come and take your seats up there. We're going to have a very candid discussion on the recommendations that you came up with. So for the different groups, the RDCs, the cows, the medical practitioners, please, we had 4 groups. So I would request the 4 members to come and take your seats. Chair, were you the one who was, oh yes, ma'am. Okay, the 4 members, please come. Come and take your seats. One more. Okay. Karibu, thank you. Earlier we had thought we would do presentations, but I've been informed our time. So you'll perhaps look at those for your reference as we're speaking. We had general questions of how can we improve our healthcare in our region, right from delivery of medicines to the staff, to the workers, to the monitoring system. We're here because this assembly is here because we're trying to look at solutions and what can we do better to serve our people in the region better. So thank you once again. Perhaps I'll stay here so that we can interact very well. Let's start from the team of the RDCs on what were the key resolutions on how we can monitor people better, or the health service system better. What did you come up with? We were really excited to hear from you. You're welcome, ma'am.
Thank you very much. My name is Najuma Juliet Senkole, RDC Utebo, representing the group of RDCs. We had 4 questions. The first one was, what mechanism have we instituted to curb theft of drugs and medicines? So the mechanism, we are saying that the system has been there, though it needs strengthening. The first mechanism, we agreed that we should do tracking of medicines right from NMS to delivery to the district. How is this going to be done? All RDCs should be getting alerts. We have been having a challenge of change of districts. We keep on being transferred. We are requesting that the DHOs take charge immediately. You get a new RDC, send the number to NMS so that the alerts can come. We get to know when the medicine is in transit. Another mechanism was the office of the RDC should have a delegation to delegate on witnessing the receiving of medicines in the district to the last dot. Because the RDC cannot be in each and every facility, so at least we delegate. We have the GISOs at the sub-counties that can witness the receiving. Medicines received in the districts are taken to farthest facilities. We need those committees. We need to strengthen the committees, the health management committees, to make sure that as the medicine comes to the facility, the chairperson of the health management committee and other members are there to take note of that. To use the RDCs that should do capture every time that we receive the medicine, we need to get reports to capture, to keep records, and to track the medicine. The district should summarize copies, the reports. This one is through COW, and the DHO have a summary of the copies to authorities, different authorities. The chairman should have the records of how much drugs and medicine received, the office of the RDC, all of us, to help us in monitoring when we are doing sport monitoring. The second question was, what do you do when you are, what do you need to do when someone you hear that has stolen drugs as RDC or any other leader? We need to have sport monitoring immediately. We go there and give guidance. We have to give guidance and reconcile. Like doctor has said that however much we are supervising, we don't need to intimidate people, but give guidance and reconcile those people. We have to check the stores. Sometimes when they bring medicine and take to the last facilities, we don't know how the drugs are stored, how they are kept, and whether they have carried empty boxes. So checking on the stores is very important. We need also to check the requisitions, the requisition vouchers that were delivered, to balance whether the drugs delivered and the vouchers are tallying. From monitoring committee teams, we have to make sure the sub-county chiefs and GISOs, these committees, are strengthened and also get alerts. Sometimes NMS release medicines going to different districts. You find that one box or two boxes are full and another one is half. So we need to make sure that we counter, we cross-check with the numbers that have been sent together what is in the boxes.
All right.
Verification of import is very important. We verify the medicines and also to weigh the boxes, the kilograms that came from NMS and which has been delivered. The third one is, what progress have you made in building more effective sustainable monitoring system? We have whistleblowers. So we have to encourage whistleblowers in different districts, in different places, to keep us informed, causing arrests and prosecutions for those ones who have stolen the drugs. Getting information from the community is also very important, because we will be empowering the community members. Routine feedback to encourage the community also to own that, and also to train people on ground to help the health center 4s and the 3s. The district security teams must make an agenda, put it a drug agenda, wherever we have DSS, to get information.
Okay. Maybe we can hold it there, and then we'll proceed on the next round of questions, if that's okay. But I think we have noted those quite close. Is that all right?
Lastly,
okay,
just very few. The last number, what are your asks? Our requests as RDCs, government should invest in biometric machines to help the health centers. We are requesting, we have a budget, at least we have that fuel, but it is not enough for monitoring, and also capacity building for clinical officers, and also RDCs in monitoring. We requested the healthy monitoring unit to equip us with more skills. Thank you very much.
Thank you very much, our dear RDC. Can we clap for her? Thank you. I think we will get some time to give some thought on that, but thank you very much. Let's go to the medical practitioners themselves. You asked for a salary increase, we gave it to you. We have done everything humanly possible. What more do you need? But we'd love to hear from you. How can you serve better? What are your challenges? What can you do better? What do we do moving forward? Ma'am, you can switch off your microphone for avoidance of feedback.
Thank you, Solomon, and to the audience once again. How long are you giving me?
10 minutes.
Okay. I'm presenting on behalf of the DHOs. I think they asked me to present such that I tell the young DHOs and the young health workers on what the elders used to do, which is maybe the missing link now.
Can I just come in here? There's a section for DHOs.
Okay.
Yes, but then Sunday is the one I think who is for the medical practitioners. If I've just been, Enoch has just whispered in my ears. Sunday, you're pharmacists, you're medical workers, what can we do better? We've done everything we can. You're welcome.
Thank you so much for this opportunity to present on behalf of the health workers. The challenges of health workers are enormous. I don't want to go into that. It's true, enhancement was made, and that has not translated very well into service delivery. And what you asked us is what can be done to enhance the performance of human resources for health. So in terms of human resources, one of the things that can be done is support to the health workers, both internally and externally. Sorry, my laptop has gone off, but I have the information here. So support to the health workers internally within the same facility, that can be done by the in-charges, by the heads of departments, to ensure that there is continuity of service in the different points. The other thing is activation of rewards and sanction committees in the different facilities. They used to be called disciplinary committee, but right now the term has changed to rewards and sanction committee. So most places you'll find that these committees are not functional. And also the terms of reference for these committees, there is a saying that these committees are not so biting, and health workers have grown horns, and we need to revise the terms for those committees so that when they make recommendations, it can be taken up. And also health workers can fear to appear in that committee, but appearing in that committee now, they don't take it that serious. So the terms of reference for that committee needs to be, we need to strengthen the capacity of the rewards and sanctions committee. Then when it comes to leadership, spot checks are very important from all different levels of leadership, spot checks, and then documentation of work done. HMIS is a very good tool of the work done. Why we say that Mbale Regional Referral Hospital is the best regional referral hospital in the country. It's because of documentation, the reports. So we may lament the quality of service, but there's also documentation of the work that has been done. Then, like the RDC has said about the clock-ins, the biometric machines, we can have this in the different facilities so that we are able to track attendance. And then the HR departments can always give a report on attendance. I hope the HR department in the districts, for us in the hospital, we have a fully fledged department. But because the districts are handling all the different cadres, production, agriculture, so the HR department should dedicate one specific office to handle the health sector. Then also, we are doing appraisal, but there is a component of the quarterly performance plans. Appraisal is done at the end of the year, but there is this quarterly performance that we feel the HR department should strengthen. Now, one of the key issues that affect health workers is accommodation, especially health workers that provide emergency services, like a midwife, a medical officer. Of course, these people, when there is an emergency and they are staying far away from the facility, it will affect their availability. So the district leadership should really take into at least providing basic accommodation for the health workers. Then the leadership can take, when it comes to extortion of money from patients, we can use the principle of shame, expose and shame those who are caught, and then use carrot and stick on those who are caught, those who are extorting money. And then one of the big issues is supportive leadership and mentorship. Sometimes there is a lot of harassment of health workers by those who come to support. And in my group, the group members told me to inform the HMU that can you be more friendly when you come to the facilities, that there is a lot of harassment, and sometimes you actually see people running away from the facilities when they come. So supportive leadership, and then when it comes to supportive leadership, when it comes to promotions and appointments, can it be done on merit? Then there's some very effective and supportive staff. You go to facilities, like you find an in charge, the facility is very clean, the records are on point. But when it comes to promotion, this officer will work on that level for a long time. So we are saying, can we identify some of these people and reward them? Probably when there is an opportunity for promotion, let it be so. So capacity building in terms of accountability for medicines is very important. Updating of all the stock management records, like the stock cards, the electronic systems. Because that cadre, the staffing level in most of the facilities is very poor. We don't have a lot of assistant inventory management officers, the dispensers, the pharmacists. So as we advocate for recruitment, we are also advocating that these people should be mentored so that we don't have a lot of issues of accountability. Some of them may be very ignorant. They may just need mentorship. And then when it comes to equipment, the health workers should be able to update the inventory list of equipments, and then also facilities should have a minimum budget to purchase some of the basic equipments. For example, a BP machine, a thermometer, some of those that the facility may be lacking. So the facility in charges should have some capacity to purchase some of those items. Health information systems, this is where all the information, the performance of the sector will be measured by the information that we report from the facilities. So these people should be mentored and their capacity to ensure timely data collection, reporting, and ensure completeness of data. Because if it's not complete, it will not be helpful. So then once these reports are made, we're also asking the district leadership, can there be dissemination times, probably quarterly, monthly, so that we discuss the reports that we are generating from the districts? Thank you very much.
Thank you. It's interesting that medical workers want stricter management policies. The rewards committee and the disciplines committee need to be strengthened. Dr. Droel is here, listening to you very, very carefully. Remember yesterday he told us about the different type of staff, right? Chair, you remember? Okay. Thank you very much. I also know that the Ministry of Health, with support from the World Bank, had started the construction of residential places for health center tours. There's a project, Dr. Droel, I don't know if you know about it. At health center tours, they constructed places where medical workers would sleep so that they are closer to the facility. I don't know if there's an expansion program on that, but he has put it up very clearly that sometimes for such, the midwives and people have to be on ward all the time. But thank you very much. It's now time for us to hear from the DHOs. The DHOs in the room, what can we do better? You have 10 minutes, and those 10 minutes start now.
Thank you so much. Thank you so much, Solomon. The audience who have been chosen to present on behalf of the DHOs in Bukedi, Bugisu, and Sebei on what we have done, but because of time, allow me focus mostly on what has been working for us as a region and what we need to be done. My chair was Dr. Wangisi. He's the one who chaired this group, and he has approved this presentation. So in our region, for us as DHOs, we're given to talk about mostly the attendance to duty and absenteeism and what we are doing. For us, with the support of IPs, we have done a lot to improve absenteeism, as you saw from the region. For example, you saw, for example, Manafa dropping from 69% absenteeism to 8%. Those are the mechanisms we have put in place. And what do we do? Duty roster and duty scheduling, attendance to duty books. These duty books, we always draw a line at the end. If it is, facilities agree, and we say we are closing the book at 8:30 at 9, or we give a time where someone should be accountable. Then we close the books. That mechanism has helped. Some facilities still have biometric machines, and if you analyze, those facilities are doing very well. For example, Busiyu Health Center 4 in Mbale District, Mukuju was #1 last financial year in the country. Tororo Hospital, Palisa Hospital, Namatala, and Bufumbo Health Center 4 and Budadiri Health Center 4. So some have. Then annual leave rosters, we pick much interest in that, and also the appraisal forms. As a region, the spot checks have helped us a lot, and this one has been supported. DHOs, because we really have, the DHO's office is really underfunded. We have to agree that. So spot checks as a mechanism, it is very difficult for them to move around. But the IPs in the region have come to give us a hand in terms of fuel to move around, and that's why you see that absenteeism reducing. And the compliance to duty attendance, where everyone should be held accountable. There is also capacity building of the UMIC, the health unit management committees, and all our committees in the region, except I think one district, if I'm not mistaken, were oriented with the support of Uganda Health Activity, and this one has strengthened that that the UMICs know now their roles of supervision. Then some districts have attached DHT members to specific health facilities, and there is also multi-sectoral support supervision where some districts are having the whole, the COW, the DHO, and the LOC5 political moving at once to go and it is not technical supervision, but overall supervision of facilities. Now, we still have the rewards and sanctions committees in place, but the ones at the district level are functioning fully. The ones at facilities, we are still having a challenge there, and that is where we need much support. What we are doing as a region is rewards and sanctions, where we are considering performance for promotions, and then on the other side, then sometimes just public recognition, a thank you in public like this. Thank you. You make the midwife stand up and tell them, thank you for, she's an example. You are going to change like 10 of them in the room, and that is what we are doing. Certificates and the promotions, I talked about it, is what we are doing. There is an issue, a gap at the health sub-district level in terms of support supervision. That is a challenge, and at facility level, where we want to promote internal support supervision at the facility. And this is one of our key areas when we are going for support supervision. Then the health sub-district should be able to supervise the facilities under, and they should always give the facilities feedback. Some districts are also implementing the work indicator staffing norm, norms, where you need more health workers. For example, you have 2 health center 3s. One is having 90 deliveries, another one is having 20 deliveries. You don't stick that a health center 3 should have this number of staff. I will suffocate this one which is having 20 deliveries because and I add on the other one which is having more deliveries, so that there is value for money and the staff are well utilized. And this is working very well in Mbale district, Bulambuli, Sirongo, and the other districts in the region. There is an issue of the rewards and sanctions at the facility is not well handled. And as DHOs, most DHOs in this financial year's worker plan have made sure that some funds are allocated, and this was supported by also our IPs to make sure that we functionalize the rewards and sanctions committees at facility level. What are our action plans? As some have mentioned them, but as DHOs, we are struggling with low staffing levels across board. So we are requesting for provision of wage and clearance by Ministry of Public Service. Provision of wage, the responsible person is the Ministry of Finance to provide wage to the health sector. Clearance by Ministry of Public Service. I know they are here, they are represented, and we request the time frame is immediate because people are suffering. Then we request also the cows to write seeking for more wage. They also seeking for clearance to recruit. Then there is, we are struggling with an issue, as many presenters have mentioned, poor attitude among staff. We know mindset change is the most difficult thing, but once it is handled, it is a game changer. So can we have a training on mindset change and customer care? We have, I'm happy Professor Maswa paid me a visit in Manafa, and it played a big role on this specific aspect of mindset change. Low motivation of some health workers caused by salary discrepancies and career path. We need the Ministry of Public Service to harmonize the salary discrepancies. For example, Solomon, I can give you an example of the data staff who have the cold chain assistants. They have been on strike for months, but we are happy that the technicians were catered for. It has been solved, but we also have a challenge of the cold chain assistants. Then those ones who handle our data is key. Then we have the DHOs themselves, who were forgotten and they are paid. You know, we have medical and scientists, and we think they are paid as scientists. And that is why you are going to see a district, Manafa advertised 4 times for a DHO, but they never attracted any. But do we know why? It's because motivation is low in the office of the DHO right now. This is what the DHOs were saying there. And there's not even structure for the DHO's office. So Ministry of Health together with the Ministry of Public Service to come up with a clear structure for the DHO's office. And MPH is not considered a specialty of recent, I think, 2 years ago. So I think this is what is causing, again, other issues. Just to summarize, the new health structure should also capture career path for some structure, for all cadres. Then constituencies without health center force abandoning the regional referral. So can we put the policy in place so that we make sure that most of these constituencies which are having high populations, we put their health center force. And lastly, districts lacking substantive DHT. I'm talking about the DHT. Normally the focus is on the DHOs, but we are saying the whole DHT. You are going to find some districts in our region, the whole DHT, you find only 1 substantive or 2. So can we revise the minimum qualifications for DHOs so that probably they are too high. It is at principal level, which is not there in the district. If you don't have a hospital, it is not there. So where are you going to get them? There are very few. Then some DHOs have minimum, and part of the DHT have minimum requirements, but they are not yet promoted. If you have a DHO in acting position in your district, this is to the cows, the RDCs, and the LC5s, who have minimum qualifications. Can we promote them and we address this gap? Thank you so much.
Thank you very much. Thank you. Wow. This is a spotlight, right? I saw people writing this down. Dr. Driwali, this is falling directly under you. We will be having the assembly paper that captures most of the things that have been mentioned here, and we will share it to all your emails. A lot of the concerns that the DHO has been pointing out, has been pushing it to the COW. The Chief Administrative Officers would love to hear from your side. Also to note, I think it's the practitioners who are saying that every time the State House Health Monitoring Unit comes, the medical workers run from the ward, a lot of chaos. I think it's you who had said it. How can we do better? I think that area I saw Dr. Dreali writing it down. But together we can look at a way forward. We would love to hear from you. You have 10 minutes. Kao, you're welcome.
Yeah, thank you very much. I am called Charles Kumakech Oruba. I am the Chief Administrative Officer of Kapchorwa District Local Government. Our group comprised of the district chairpersons, the city mayor, the chief administrative officers, and the city clerk. And you know, when you mix the politicians and technical people, you can guess what you expect. Initially, I wasn't supposed to be the one presenting this. My senior colleague, the Kao Boduda, was supposed to have done it, but in the interest of capacity building, they chose me to do so. We were given 7 questions to respond to, and I think our questions were more than any other members of the panel. So, but I will present it precisely the way it is, and for the fear of not being reprimanded by my bosses, I will present exactly what they discussed without adding anything. The very first question we were faced with was, what mechanisms have you instituted to manage health workers' attendance to duty, and what are the results? We usually communicate to the staffs about the provisions of the standing orders and its implications should you violate it. We put it very clearly, and in any case, they know this right from the time they joined service. But we just communicate as a way of reminder so that they should know what they expect if they go astray. We also have staff attendant registers that specifies the time you should come for duty and when you should leave. For us, we don't leave it that you discuss and say 9 or like the health people do. For us, it is a strict one. We know we should report by 8:30 and leave by 5. Anything short of that is a violation of that provisions. So we also analyze those duty attendant registers. In some districts, it is done on a weekly basis, and in some, it is on a monthly basis. And we look at it. The results of the analysis is submitted to the DHO and to the CAO for appropriate actions. Apart from those two, we also carry support supervision, and some of these supervisions are the routine one that they know, but some are impromptu to these facilities, and the outcomes of those supervision is discussed in technical planning committees, in senior management, and appropriate actions are taken on those who are found falling short of attendance. This falling short of attendance can attract a lot of sanctions, can attract a lot of disciplinary actions, which can be by way of warning, verbal warning, can be by way of written warning, can be by way of even withholding your pay, should it go to the extreme. When you fail to do that, of course, we now take those disciplinary actions. We invoke the provisions of the standing orders, and you are compelled to comply. If you cannot comply, you may be submitted to the commission to exit service, because we want a disciplined force. What result has this given us? We have achieved a bit of improvement in duty attendance to the level of over 89%, and our efforts have not yet stopped. We are still continuing to do this. We have also seen an increment in the uptake of health services and the customer satisfactions in the health services, and this can be seen when we see increment in the attendance in OPD and other services that are provided in those health facilities. The question number 2 that we were given to respond to was, what progress have you made in building a more effective and sustainable supportive supervision system at all levels of health service delivery. And we noted that one thing that is being done across the regions is that they have quarterly review meetings and support supervision with the various stakeholders in health facilities. And the results of those supervisions are usually disseminated, discussed, and they get way forward on what they should do. We also follow up on the actions and the recommendations from those support supervision visits, which is all inclusive. And we also require the DHOs, the in-charges, to give us weekly reports in some districts and monthly reports in most. And we also demand them to present to the senior management meetings and in technical planning committee meetings, and even to the committee of councils, and even council itself, reports of their performance, so that recommendations are made at all those levels. The third question we were required to respond to was, what success have you had with using data to deploy staff? And our response to this was that we don't deploy staff just anyhow, but we deploy them based on the available information. And some of this information are like information on the workload, information on areas of hard to reach, information that are gathered from the health management information systems. But even our deployments of these staffs are usually guided by the DHO on how he feels service delivery can be improved given all the facts that he may have on the ground. Our question number 4 was, what are some of the most promising innovative measures being implemented on health workers' performance, and what results has been shown so far? And our response to this across the region was that we always recognize best performing health workers as a way of innovation and as a way of recognizing their performance. And this we do in many ways. We can thank them and say, thank you so much for the good work you are doing. If such a word comes from the COW, comes from the LC5, comes from the RDC, it's a very good motivating thing. But we also give them certificates. And in most cases, this is done at the end of the financial year. But we also recommend them for promotions based on their performance. You do very well, performance, we say that promotion is not, you don't ask for it, you deserve it. And you deserve it based on your performance. So we reward such good performers by recommending them for promotions. But we also sometimes give them assignments, give them positions of responsibility in recognition of their performance. We also engage them as a way of recognizing their performance, but in allowing them to do mentorship, in allowing them to do trainings of others. You cannot train others when you are not above them or when you are not doing better than them. And we think that's a better way, an innovative practice that we have used to make them get better. And the result we have gotten from this include retention of staff in the hardest to reach areas where no one would wish to go. When rewarded, this person will insist and stay in such a hard to reach place because he knows he's being rewarded and for his good performance. Question number 5 is requiring us to provide the status of the functionality of the Reward and Sanction Committee. And we are saying that our Reward and Sanction Committees are very, very functional at the district level, at the city level, even in the general hospitals and the health center force, but they're not doing very, very well at the sub-county levels and other lower level health facilities. They meet on a quarterly basis as a requirement, but they're only not limited to that. They can also meet as and when there's an urgent issue that requires their attention. The second last question was requiring us to talk about the progress of the rollout of the balanced scorecard. The balanced scorecard, as you know, is a new method of performance assessment, and it's just being rolled out to most districts. Our principal human resource officers and the district planners have recently been trained in this new approach, and they have come back to the districts and rolled it to the heads of departments and heads of sectors, and are now at the stage of moving to the lower level local governments and the health facilities to roll out this as well. And we think when this is well done, it will give us the results that we have, that we really need from those workers at the health facilities. Our last question was on what your asks to maintain well-performing workforce. Our asks, the shopping list is quite long, but I will cut it short. We are also asking for improved staffing levels by giving us adequate wage. We are asking for prompt clearance of recruitment, and we are also asking for operationalization of the new staffing establishment structure by Minister of Public Service, and specifically for the health department. We are also asking for adequate equipments and tools by Minister of Health, local governments, so that our health workers perform their duties better. We are asking for inadequate infrastructures, OPD, theaters, X-rays, wards, and so on. All this can come from Minister of Health, from partners, from even the local governments. And we are asking for timely and regular supply of medicines and other essential supplies to facilities so that there is no stock out.
Okay.
And we are asking that the Minister of Public Service should allow us implement our plans, especially the capacity building plan, the recruitment plan.
Okay.
Thank you.
Thank you very much. A round of applause to the representatives from the different groups. Thank you very much. Kindly share those presentations with the team. We are going to compile all of those into one single document that we will take to another level to discuss these challenges and opportunities that lie ahead. Another round of applause to my panelists. Please go and take your seats. Thank you very much. I have 10 minutes to close this assembly. So I will do it really quick so that we can break off and go and have lunch, then go home. I would love to invite Dr. Bo, who is the director at the Mbale Regional Referral Hospital, to come and present the action points real quick. Dr. Bo, I've given you 2 minutes, after which we'll have the representative from the partners, and I'll have Dr. John Mayoka, who will also speak for 2 minutes. I will also invite Mr. Andrew Bunya from Life Care Uganda to come as well and give about 2 minutes presentation. You're very welcome, Dr. Bo. Karibu.
So good afternoon, everybody. I hope you have had a nice assembly. Have they been loaded, please? I need some support from the IT team, I think. Okay, thank you. So those are some of the resolutions we had, and I think they had been put into sub-themes, but you can all see them. Number one is on human resources. It includes things like increase the staff, address absenteeism with biometric machines, improve leadership, and legal action may be needed to overcome the recruitment barriers. I think this refers to the challenge that the LC5 chairman of Busia raised. Number two was about medicine and supplies. It's about strengthening the tracking and monitoring systems to prevent theft, improve communication about deliveries. I think this was raised by the RDCs, and address inconsistent drug supply. The issue on community health was about enhanced community education on health-seeking behaviors and rejuvenate local information sharing. Health financing, it was about explore innovative solutions and local partnerships to address funding shortfalls. For malaria control, it was about improving net distribution, documentation, and adjust medicine stocks to account for seasonal malaria variations. On maternal and child health, there was something to do with tackling the high teenage pregnancy rates, improving maternal death reviews, and ensuring that updated data on health indicators is collected, and resume immunization efforts, which seem to have gone into a bit of a limbo post-COVID. About HIV/AIDS, it was about strengthening social mobilization, improving art services, and addressing art adherence issues. For tuberculosis, you can also enhance TB-based programs and integrate TB activities into primary health care. Health infrastructure, reduce congestion at Mbale Regional Referral Hospital by improving lower-level health centers and addressing transport and equipment shortages in those areas, those centers. On health sub-districts, there was an updating the health sub-district strategy to reflect the current district structures. On neglected diseases, establish rehabilitation centers in each district to cater for NTDs like nodding syndrome. On outbreaks, strengthen enforcement of COVID-19 SOPs, increase vaccine uptake, and ensure risk allowances for key hospitals. I wonder that, okay? So those are some. I don't know whether, do we need to discuss these and put more flesh on them? I know, Secretary, that you can guide, or was I just to read them and leave them at that? Okay, please. Is there any microphone? Any microphone around, please?
Yeah, Stephen Wasike Mugeni is my name, District Chairperson, Busia. My attention has been drawn to the way ministry communicates to the districts, thereby the information not flowing the way it is supposed to flow. Ministry usually writes to the chief administrative officers instead of writing to the district chairpersons. Why it should write to the district chairperson is there are some actions which are supposed to be done by the boards. It is the district chairperson who appoints the hospital board. Now, are you telling the cow to tell the district chairperson to institute measures with the district board? When the information comes to the district chairperson, he will not do anything without either sending it to the cow or the relevant body. Now, when you write to the cow and exclude the district chairperson, you are introducing protocol issues, because the local government is based on a council. Then the council is based on the executive. Then the executive is, the head is the district chairperson. So the mobile district is the chairman, not cow. For Busia, the mobile district of Busia, from 14th May 2021 to 12th May 2026 is me. Yes, I am the mobile district. I am the official agent of the district. By this law, you are free to read. Now, this brings me to another question. You know, the problem with our friends in the medical fraternity, they sometimes abbreviate things. 7 out of 14. Then you don't understand what they are saying. Now, for you, you may not also understand the law. But the law says the head of the district is the chairman. Yes, he's the head of the district. So when you write and expect the cow now to be the one to instruct the chairman, you are making errors. So please obey the law and stop the unconstitutional communications.
Okay, I don't know. Should we? Okay. All right. Okay.
Our God is good. God is good. And all the time. My name is Atama Gabriel. And by the grace of God, I'm the chair of cows and the cow of the biggest district in this region. That is Tororo. Now, I am a cow, you know. We are administrators, isn't it? We are managers. But I'm also a lawyer. LLB, upper second. Now, I want to give the legal provision of the law. You know the beauty of government, you don't just do things far. We are guided by the laws in this country. Now, when you go to what they call the public service standing orders, the latest version is 2021. It tells you actually how you are supposed to communicate from the ministry to the district. You be orderly. Be orderly. So what happens when you go to the public service standing order? I want to interest all of you to that provision. It says when a ministry, one ministry is writing to another ministry or government department, the letter has to go to the accounting officer. So this business of saying who is bigger, who is what, I think it doesn't matter. What we are doing, we are following the what? The law. Okay. And I would like to request and kindly request the chairman to respect that provision of the law. I beg to submit.
Okay, thank you. I think, we shall consult on that one. I think we shall consult on that. But I think, I'm sorry, in the interest of time, I think we may need to continue this discussion after here. And I will beg that the officials from the ministry can guide. Please forgive me, I was given only 2 minutes. And I don't want to cause, let us not end with throwing cakes at each other, please. Okay, so thank you. So I'm sure we shall get further guidance on this. And the issues which have been noted, we shall do that. So thank you. Serwanja, please take over.
Dr. Bo, you opened the Pandora's box. Okay, may I call this meeting to order, please? Thank you very much. May I call this meeting to order, please? All right, I want to invite Dr. John Mayoka to come. He's representing partners to say something in 1 minute. Dr. John, you're welcome.
Sorry. Thank you, Solomon. I am actually not a doctor, I am a pharmacist. Good afternoon, colleagues. John Wilberforce Mayoka. I work with MSH under the USAID Strengthening Supply Chain Systems activity. I've been given quite an enormous task to appreciate all the partners in just a minute. I'm afraid that's not possible, so I apologize in advance. Yes. So thank you, first of all, to all of us that have made it here. And I mean all of us, those that are attending physically and virtually, for having put aside time to attend to this very important function. And I hope whatever has been discussed here will be put into action to improve the health of the people that we serve and live with. I want to thank the Ministry of Health officials that made time to come here. I also want to thank the coordinating mechanism, Mbale Regional Referral Hospital, for doing an enormous job to see that we all make it here. I also want to thank the development partners, in this case, USAID, UN, Global Fund, EU, Oxfam, for allowing the implementing mechanisms tap into the resources that you have given to do implementation of activities. Many thanks to UHA. I know a lot of resources have been picked from their pocket to make this happen. I don't mention the figures, but somewhere in the double figures, about 50 million, if I may. LPHS, LSDA, AMREF, IDI, MSH, and all others that have made this possible. I also want to thank the private sector, the banks, Stanbic Bank. I'm told they have donated some mama kits, one of the very critical commodities in service delivery, Housing Finance Bank, and also want to thank the insurance companies, Prudential, Jubilee, Civil Aviation Authority, Honest Traders, Wide Spectrum, Abbott, who also invested a lot of good resources in double digits in terms of millions, Pepsi for the drinks. I also want to thank the organizing committee. I was talking to one of them at the back there, and they say they're having a headache. It's been a very tough few weeks, and I hope as we get into the weekend, they'll get a bit of rest. Thank you very much to the organizing committee. Thank you also to Mbale Courts View Hotel for hosting us. I'm even told the venue was given sort of free. So thank you very much to Mbale Courts View Hotel for hosting us. And of course, to the media that has made it possible for the people that are not here to be able to view us wherever they are. So thank you very much to the media company and to Solomon for the great job of coordinating the meeting. Thank you, and thank you very much.
Thank you very much. We are making progress. We just have 2 more people, and then we can get into the award ceremony. I want to invite Mr. Andrew Bunya from Life Care Uganda to as well come and represent the pharmaceutical and drug distribution stakeholders. You're very welcome, Andrew.
Thanks, Solomon. Good afternoon, colleagues from the medical fraternity and the political wing. Health officials from the Ministry of Health, colleagues from the political wing, all protocol observed. My name is Andrew Bunya. I work with Life Care Diagnostics. Life Care does represent Abbott in country, who has been one of the sponsors of this health assembly. We are privileged to be part of the health systems in Uganda in a public-private partnership. We've been running this MOU since 2016, and we run it on a 3-year term. We are in our third term running. So in yesterday's breakaway session, which some colleagues missed, we had a pertinent discussion, and I've heard it from one of the RDC representatives, the issue of drug theft. It's a broad discussion at all levels, but as a private sector, how do we come in to help in this? I think one of the key take-homes from this assembly, number 2, was also addressing that. So as a private sector player in this industry, how do we come in to help? Even before commodities leave NMS, because we all appreciate that NMS gives these commodities, but along the way things disappear. So how we come in to help is we are piloting something called an FC. We are going to embed, I'll talk from the perspective of the determined strips. So we're also selling this idea to other manufacturers of drugs. We are going to embed what we call a chip in these test strips, in that when a health worker does a test, you scan this chip. It is going to be barcoded, you scan it, and it transmits that data directly to a central server somewhere at MOH, and it's going to be like a breakdown, as in it's reducing balance. If we gave you 1,000 tests, we expect that every time you scan, it reduces. So we're going to be piloting that. It's started in one of the countries in East Africa, because this is a question that ministry is asking us, you as a private player, as a manufacturer, how do you help in this vice? Because we all appreciate that it's a fact. It's a fact. So we came up with that innovation recently. So we think from the manufacturing side that it will help address the issue of drug privilege and kids privilege in the whole region and the globe as well. So thank you to the organizers, UHA, Mbale Regional Referral Hospital, and all the other partners that came in to put this assembly together. On behalf of ABOT, we pledge that we shall be supporting these assemblies. I'm meant to understand it's going to be an annual event. So we shall be coming in to support every time we are called on. Thank you so much. And have a blessed afternoon.
Andrew, thank you. Andrew was my OB also, so it's good to see that you're supporting as well. Okay, we are going to the last part of our session where we're going to give out some awards and some certificates. I am also happy to announce that Stanbic Bank has given us 150 mama kits, which are right there. Thank you very much, Stanbic Bank. We will speak more about where they are going. They are right there. The minister had requested that this go to Mbale Health Center 4, but we will see how the district, whatever the district decides on. Well, it's the minister. She requested, but we will see. The district's health officer will make a decision on that. Okay, I want to invite the following on the podium. I want to invite Dr. J.B. Wanyae to please come. I want to invite Dr. Obo, please come. I also want to invite Dr. Augustine Mwezi to come on the podium. Please come. Please, Karibu, you can come to the podium. Okay, Dr. Wanyae, I wanted you to speak on the mattresses that were donated yesterday, just briefly, just for people who were not there, as well as Dr. Obo, and appreciate the partners who have supported us as we officially hand over the mama kits. Do we have a portable microphone? Oh, thank you. Thank you very much. Dr. Bo, I think you can lead this process of speaking about the different donations that have been made, and then we can officially hand them over, after which we will go into the awarding ceremony. But you can all say something about the awards and the event as we close. Karibu.
Okay, thank you. I don't really have much to say, but as we saw yesterday, the community in Kampala that comes from Bulambuli got together and donated a number of mattresses yesterday, which we also, the minister handed these over to the team from the district and the partial health facility, which was selected. And today we also have mama kits here that have been donated. I think the minister recommended they go to where she had said, because that district and that health center had expressed their need for that. So those who ask, get. So they asked. Thank you.
Thank you very much. Perhaps before Dr. Augustine comes, I want to invite the team from Stanbic Bank to come and officially hand over these to Dr. Wanyai, and then Dr. Wanyai can hand over to... I don't know, but firstly, I think I don't want to cause chaos here, Dr. Wanyai, by saying where they are going. The team from Stanbic Bank, please, you can say a word or two. Thank you very much for your generosity as you hand over the mama kits to Dr. Wanyai. You're welcome.
All right. Thank you so much for giving us this opportunity. And thank you for supporting this noble cause. And my name is Daniel Koluo. I'm the branch manager, Stanbic Bank Mbale, which is the regional branch. I'm here with my colleagues. Julius Kigenyi is the regional acquisition consultant, and then our insurance consultant, Emma. So as a bank, we support health as one of our strategic arrangements as a bank. So we believe that Stanbic Bank as a #1 bank in Uganda, we've done a lot in terms of supporting the community. 1, in terms of education. 2, environment. 3, financial literacy sessions. Most of us here spend a lot of time in the hospital, but engage us who come to your institution. I'm happy that the officials, the decision makers are here. Invite us at all levels in any of our branches to come and take you through the financial literacy session. You do it for free. So it's better for you to know more about finance, since you know Mamati, but also you know, I know more of us do a lot of private work. So please get to know about finance. Even our schools, we support students in terms of finance. Here in Mbale, we've done a lot in terms of supporting the medical fraternity. A couple of the issues we've done in Mbale. 1, in Namatala, we gave out the operating bed as well as the delivery bed. In Mbale Regional Referral Hospital, I'm happy Dr. Boy is here. It was graced by our CE. We gave about 6 baby cribs and 1 oximeter, pulse oximeter, and then mama kits. Maluku, we gave out beds, patients' beds. Namakwekwe, we gave out delivery beds. And we shall not stop there. We shall continue supporting the medical fraternity. Today, we've delivered mama kits to support in noble cause, 150 mama kits, which is worth 5.2 million. And also, I think we extend the financial support toward this noble cause, cash money of 2 million to the organized community. And we want to say that since this is a Bay, Bugisu, and Bukedi region, please, and Sebe, please engage our branches wherever you are. We do a lot in support Mego. Thank you so much for this time.
Thank you.
And I think you can hold on the thing.
All right. Yes, Dr. Boy, you want to say something?
No, I was just saying we're handing this over.
Okay, let's hand over to Dr. Wanyai, please. Dr. Wanyai, please go and receive the mama kits officially. And Dr. Augustine, for a photo moment. Thank you very much, Stanbic Bank. 150 mama kits. The minister requested that you put that number to 500. She appreciated you very much yesterday, but thank you very much for giving back to community. We appreciate you. Dr. Wanyai, do you want to say something? Yes.
Yes, we appreciate Stanbic Bank for this gift to the community of Mbale region. The minister, when the community of Bulambuli, the doctors who come from Bulambuli, donated some mattresses, and she expressed to Stanbic that they could donate about 5,000 mama kits, which will be distributed. I think this is the beginning. I want to believe so. And for that matter, we are going to discuss with the DHOs how to continue with this 150. They are very few. So we are going to agree who takes what. But in that request, as you know, it came because of the donation of mattresses to Bulambuli, Mbale Health Center 4. But for now, after here, we just have a small dialogue with DHOs and have the kits reach the service, the people who need them. Thank you so much, Stand Big, for fulfilling one of the greatest part of the theme, saying harnessing partnership to build resilient health systems in Eastern Uganda. The rest, please follow suit, donate something to build the system. Thank you.
Thank you very much. Thank you, Dr. Anye. Thank you, Stand Big Bank, for making this possible. We're now going into the awarding ceremony. Doctor, thank you very much for saving me the fire of saying that these mama kits were going to a certain health center 4. I am sure that the district will sit and agree on how they are going to be distributed very well. We are going to go into the awarding ceremony. We will, please, because of time, you will just come receive the award and then shake the hands of our top leadership here and then go back. This is to appreciate everyone. We want to start with Dr. Godfrey Mulekwa, DHO Palisa. Dr. Mulekwa has expressed exemplary leadership as the chairperson of all DHOs in the region. Let's clap for him. Dr. Godfrey Mulekwa, thank you very much. We had you yesterday representing the people very well. Thank you very much for your leadership. Dr. Godfrey Mulekwa, thank you very much. Next, we want to appreciate our partners. I need to mention that all partners have done an amazing job, but just in a special way, we want to appreciate those partners that have been working extensively in the region, including Baylor-led USID. The team from Baylor, thank you. The Baylor team works in about 15 districts, if I get the numbers right. Can we appreciate them? Where is the team from Baylor to come and receive? Thank you very much, to come and receive this award. We want to thank you so much for supporting us towards the HIV and TB prevention and treatment in our different districts. You are currently operating in 15 districts and 1 city. Thank you very much. Can we clap for them? Thank you very much. Asanteni sana. We want now to appreciate the team from USID, Uganda Health Activity, for the generous work that they have done for all of us. They're working in 16 districts and 1 city. Let's love on them. The team from, let me invite Dr. Andrew. Dr. Andrew Chero, thank you very much for your leadership. Please come and receive the award on behalf of USID, Uganda Health Activity. They have supported us in family health and health system strengthening in the different districts. Dr. Andrew, it's only fair that you stay there because you're receiving another award. Dr. Andrew is the Regional Programs Director, One Health Team Lead at USAID, Uganda Health Activity. We want to give you another award. Thank you very much for your support on resource mobilization and the successful execution of the Mbale Regional Health Assembly. Thank you very much. Ladies and gentlemen, this has been the team lead behind this. Let's appreciate them deeply. And of course, Dr. Augustine, thank you for leading the team. Dr. Augustine there is the chief of party for Uganda Health Active. Can we just love on him? Dr. Augustine has been working very hard to ensure that the programs go as detailed in the program, and of course, on the front of the family health and health system strengthening in the 16 districts and 1 city. Next, we want to welcome Damali Namuyond. Damali is the regional TB and leprosy focal persons. Yeah, thank you very much. Damali has been the best clinical mentor in Mbale region. We appreciate you very much. Thank you very much. That came with a surprise, right? Thank you very much, Damali, for working very hard. We appreciate you very much. Thank you. May God reward your kindness. Next is Mbale Esther. Mbale Esther is the Regional Quality Improvement Officer, and she has been championing quality improvement initiatives in Mbale region. You're very welcome, Mbale Esther. Congratulations, and thank you very much for your hard work. I think the rest is the district team. Mbale District emerged the first position as best performing district in the financial year 2023-2024 National League Table Indicator. The district leadership of Mbale, come, let's celebrate you. Yes, thank you very much. Mbale District. Thank you very much. Team Mbale District, karibu sana. Thank you very much. Mbale District emerged first position as the best performing district in the financial year 2023-2024 National League Table Indicators. Congratulations. Thank you very much. Next is Budaka District. Yes. Okay. Budaka District, second best performing district in the financial year 2023-2024. Where is the Budaka District? Thank you very much. Congratulations. All right, let's go to the next team that is coming. All right, thank you very much. Let's now go to Queen District. Yay! Queen District emerged third best performing district in the financial 2023-2024 Regional League Table Indicators. You're welcome. The team from Queen District. Yeah. Thank you. Congratulations, Queen District. Next award goes to the one and only Dr. Obo, Director, Mbale Regional Referral Hospital, for the exemplary leadership and support in building resilient health systems in Mbale region. Dr. Obo, congratulations. Okay, Dr. Bo, thank you very much. Next is Okello David Chiro. Mr. Okello David is awarded for his immeasurable support and execution of the Mbale Regional Health Assembly. You're very welcome. Mr. Okello, thank you very much for making this possible. Thank you. Thank you. The next award, and I would love us to stand up and honor Dr. Augustine Muwezi for making sure that this event happens, but also for steering the Uganda Health Activity USID project well. Can we stand up and honor him? Thank you very much, Dr. Augustine Muwezi. Thank you. Thank you very much for your leadership. Thank you very much. Dr. Augustine is the chief of party. Thank you very much. Okay, great. We're making progress. We're now going to the certificates of recognition. For these ones, I will call you up and then we give them real quick and then we can, quite a long list, so we'll try to catch up on the time. I'll start with Dr. Geoffrey Ndikabona to come and receive the Certificate of Excellence for his immeasurable support and execution of the Mbale Regional Health Assembly. Dr. Geoffrey, you're very welcome. Karibu, thank you. Next is my former classmate at the master's class, Madame Irene Mirembe. Can we love on her? Madame Irene Mirembe has also been behind the team for making this event possible. You're very welcome. The communications lead, thank you very much. We celebrate you. Karibu sana. Next is Mr. Stephen Karyesubula. Where are you at, Steve? Thank you very much, Stephen. We celebrate you. Can we clap for it? This is the back-end team that has been making everything. They have been preparing for about 15 to 16 days. They were not sleeping. Stephen, thank you very much for that. Next is Alan Nabawesi. Alan, where are you? Yes, thank you. This is the team that is behind the assembly. Thank you very much, Alan, for that, for the support towards the Mbale Regional Assembly. Next is Juliet Ayesiga. Oh, thank you very much, Juliet, for making sure that this event happens. Ladies and gentlemen, people work hard to make sure that such big events happen. Just organizing a birthday party can be a headache, but imagine organizing a regional assembly. Thank you very much. Next is Dr. Odot Moses. Yes. Dr. Moses, thank you very much. He has been very instrumental in organizing this assembly. Thank you very much. Humble man, thank you. Thank you very much, Dr. Moses. Next is Sharon Rechurenga. Yes. Sharon, where are you at? Oh, yes. Sharon, what can I say? Thank you very much for making sure that the event happens. These are the unsung heroes who have been behind the success of this day. Thank you very much, Sharon. Next is Beatrice Mugabire. Beatrice, where are you at? Yes. Thank you very much, B2. Thank you very much, Beatrice, for running up and down and for making sure that the event happens well and goes successful. Next is Dennis Atuhaire. Dennis, where are you? Dennis, thank you very much. Our procurement lead for making sure that everything goes well. Dennis, thank you very much. Next is Michael Nimanyanta. I hope I pronounced it very well. Michael, you're very welcome, Karibu. Congratulations for your support for making this happen. Thank you. Peter Mikago. Next. Peter, where are you at? Yes, run. Thank you very much, Peter. for the hard work you've put into this project. Next is Arthur Gimel. Arthur, where are you at? Arthur, where are you? All right, we will deliver. Is back end, making sure things work. Okay, thank you very much. We'll give him the award. Next is Enoch Balondem. Yes, the man who has been running up and down. That face is familiar to all of us. Dr. Enoch, thank you very much for all that support. Enoch Balondem, thank you. Next is Achom Belinda. Belinda, where are you at? Yes, you're welcome. Mr. Achom. Oh, Madam Achom Belinda, welcome. Karibu. Next is Inidi Kawala Kagoya. Inidi, thank you. Thank you for making sure the event is successful. Next is Jennifer Buchawa. Jennifer, where are you? You're welcome. Congratulations. Thank you so much. We appreciate you so much for all the hard work. The last one, I want to thank me for moderating very well. Thank you very, very much for that. We had forgotten a few appreciation awards, and the first award goes to Mr. Godfrey Bongole. Mr. Godfrey Bongole, thank you very much for your work and dedication as the data and information analyst for Mbale Regional Emergency Operations Center since it was established back then in 2020. We also, thank you very much, sir. We also want to honor Mr. Samuel Gidudu. Mr. Samuel Gidudu, we celebrate you for your work and dedication as the laboratory lead at the Mbale Regional Emergency Operations Center since it was established in 2020. Mr. Samuel Gidudu, where are you at? Oh, great. Okay. We also want to appreciate Mr. Herbert Issa Abiriekiria. Mr. Herbert Issa Abiriekiria, we want to celebrate you for your work and dedication as the operations manager for Mbale Regional Emergency Operations Center since it was established in 2020. Lastly, I want to thank you for coming. Thank you. Clap for yourselves. You have sacrificed your time. I mean, we all know you're very busy, but you made it. Thank you very much. On behalf of the organizers, I want to appreciate you so dearly from the bottom of my heart. It's been my honor officiating over this event. I'm Solomon Serwanja. Good afternoon, God bless, and lunch is served.